We are live now, ma'am. Shall I give the introduction, ma'am?
Yes, Sakiti, thank you.
Okay.
Good evening to all. I welcome you all for the TNFOG Marathon CME. This Marathon CME is conducted every month on the second Friday. We have 3 sessions, one for the Yuva. The Yuva's talk will be judged by the same judge every month, and the best orator will be awarded at the TNFOG annual conference. And the second session will be the update by the seniors. And the third will be the panel discussion with the case scenarios. The theme will be the same for all the 3 sessions. This month we have the theme as maternal mortality ratio. So I welcome our President Dr. Ramani Devi Madam to tell few words, and we will start the program. Ramani Madam?
Yeah. Good evening, everybody. Respected Secretary of TNFOG, Dr. Sampath Kumari, and the Chief Guest, Dr. Jayashree Gajaraj, and my dear friend, and all the faculties, that is Kartika Prabhu and other judges who are being there for this judging this Marathon CME, as well as the guest speakers and the panel discussion. I think this topic, maternal mortality reduction, is a very, very important one, because that is only going to be the one that is going to tell you the healthcare facilities that is available in a country. And it is for our own thing that we need every mother to be, that is the motto of our, as a gynecologist, we want save every mother. So by modifying simple things and following the protocols, and then we'll definitely, and referring her at a prompt time, that will help us to reduce the maternal mortality rate. So we have good speakers, good Yuvas, as well as good judges and chairpersons and the panelists and the panel moderators, so that they will enlighten us. We got enlighten the whole team about maternal mortality ratio and the ways how we should reduce it. Thanks for the opportunity.
Yes, Radhika.
Thank you.
We can go with the Tamil Thai Varthu and the program, and then you can introduce Dr. Usha.
Okay, thank you. Tamil Thai Varthu. Tip of the candle and ease at the fundus, and you give a pro movement. That is I request Usha ma'am, who is the past president of Erode Absam Gynae Society and who is senior member of TNFOG, to please introduce Jayashree Gajaraj ma'am and welcome her.
Usha madam is the first patron of TNFOG.
Good evening, everyone. And I thank Dr. Sampath Madam for this opportunity. And it is my proud privilege to introduce Dr. Jayashree Gajaraj, who is known to me for many years. And she had been a regular faculty for our Erode OG Society as well. That is how I came to know about her. And she's a senior consultant in OB/GYN in Chennai, in Apollo Specialties Hospital, and also Mangai Women's Health Exclusive MGM Healthcare. She has got gold medal in clinical medicine during her MBBS days. She's been the president of Oxy in 2008, and she's chairperson of AAC RCOG South Zone between 2008 and 14. It's been a very long period, I think. And she's a founder, secretary, and president of Chennai Menopause Society. She's president of ATN RCOG now, and SOPC Tamil Nadu chapter. She's been awarded the Best Doctor Award for MGR Medical University, and she has many publications and chapters in textbooks. So we welcome you, Madam Dr. Jayashree, and for your inaugural address.
Usha Madam, our chief guest is a good dancer also.
Okay, that part I didn't know.
Yes, Madam.
Maybe.
Thank you, Usha. Yes, very pleasant memories of my trips to your house at Erode. I think you're a wonderful host and always have been. Thank you.
Thank you.
Just that I think the topic itself, when I was looking at what you had chosen, is something that we need to probably discuss every month, not just as one CME, marathon CME, and then go on to another topic. Something we should probably be doing more and more often, because if you look at the national figures and at our own Tamil Nadu figures, we are actually doing well, but we were probably not doing as well as we were doing earlier. And I'm sure Dr. Shobha will be able to stand witness to this. There is a lot more that we can do. And how can we start doing this? Primarily, I feel we should start at the preconception stage itself. We have to talk to the younger generation when we do other camps or health talks, etc. Talk to them about preconception counseling, ask them to meet their doctors and plan their labor. That itself will be a big contribution to reduction in the maternal morbidity, leave alone the mortality. We then have to talk to them and encourage early booking so that they can plan their pregnancy, plan their labor, where they want to deliver, categorization of the labor into high risk and low risk, so that very early on we can tell them that you are probably a high risk or you have chances of becoming a high risk. Please plan your pregnancy and delivery. Then the family is then ready to move, if necessary, from remote rural areas to areas with better care, rather than trying to transport her when she's 6 centimeters dilated, contracting, baby's heartbeat not okay, throwing fits. See, we should plan it much earlier. So maybe pre-pregnancy or early pregnancy planning will again make a big difference. Not everyone needs to move from their village or their place, but those who need to we can take the responsibility of actually shifting them and making sure that good neonatal units are also available, because remember, it's always fetus and mother. So it's maternal mortality along with perinatal mortality. We should discuss the two together, never talk of only maternal mortality or only the neonatal mortality. We should talk of both together. And if we are improving one, automatically we have to think of improving the other also. In labor itself, I think CTG has come a long way, has helped all of us. When we were postgraduates, it was just being introduced. And yes, there was a lot of interventions because of it. But today we all are at a position when we know when to intervene, when not to overreact to CTGs. But it's a big help, because no obstetrician can sit with every mother in labor. And it's a very big help. With technology, WhatsApp, etc., we're able to sit at home and look at the CTG, even with the handheld device. We're able to see how things are going on. The next important thing that I have always felt, and Sampath and I have discussed this at many, many occasions, is the need for anonymized evaluation of maternal deaths and near miss patients. I don't know why somehow we're just not able to move forward. I know it's being done at the government level. There is absolutely no doubt about it. But if this information is brought out in some way, anonymized, to all practicing obstetricians, inquiries are held, decisions are made, the problems are sorted out. But we as obstetricians who are practicing need to learn from others' mistakes also, not necessarily from our mistakes alone. And so urgent need for anonymized evaluation and publication of the data. Nobody needs to be blamed because none of us make a mistake intentionally. It happens. And it's very unfortunate. See, the family may be upset, but when we lose a mother or a baby, I'm sure all of you will agree with me, we are equally upset. It takes days to get over anything like that. So when that happens, why don't we try to improve it? So that's an urgent plea. I think that this plea goes out to both Dr. Sampath Kumari, Dr. Ramani Devi, and Shobha, who is our representative at that level, to please take it forward. I think that is, Shobha, we place full responsibility on you. You should be our voice in the, circumstances where you are so that you can do this for us. And anonymize it, bring it forward. Pick me registration, I think, will help us in a big way. I know we all complained about it when it came. It was extra work for us, etc., etc. But it is a huge database and a wonderful initiative. If we enter data properly, first pregnancy, second pregnancy, all the complications, it's not just registrations. It is an ongoing database for every individual pregnant woman. So if we are able to do this, in fact, I think they want us to even enter every antenatal visit. Am I right, Shobha?
Yes.
So they want all that information, which we are not giving.
Yeah.
They just say, telling them get registered and come, otherwise you won't get your baby's birth certificate. But it doesn't stop with that. There is much more to that Pick Me registration. So why don't all of us do it? Draw out information from it, publish it. And all of us should learn from it. I think these are only my thoughts when I think of maternal mortality. And let's all get together and do this. I'm sure we can drop this 45.5 to much, much lower and single figures also. Thank you very much, Sampath and the entire team for calling me. It's something very I'm passionate about, very close to my heart. Thank you.
Thank
Thank
you.
you,
Thank you
ma'am.
so much.
Thank you so much, ma'am. We will definitely take
We
your
will all
idea.
work together to reduce the maternal mortality, madam.
We
With
should.
Shobha madam and yourself, everyone, we will do that. Definitely. The TNFOG aim is that only. We'll do that. Okay.
Thank you.
Okay,
Thank you,
Radhika.
Sampath ma'am. Thank you, Sampath ma'am. We'll move on to the next session, your session. The judges are Kartika Prabhu and Dr. Kartika Prabhu, ma'am, and Dr. Karpagambal Sairam. Dr. Kartika Prabhu is a professor, SRM Medical College Hospital Research Center, Katangulatu. She is a MMC student and she's done her MD in JIPMER, undergraduate and postgraduate teacher. Her special interests are high-risk pregnancy, gynae endoscopy, and midlife. And she has received many awards, and she's also a faculty in national and regional conferences. And we will, and I invite Dr. Karpagambal Sairam,
Good evening. Good evening.
who is our other judge. She's the EC member of OXY, consultant obstetrician, gynecologist, and fertility specialist. Special interests are fertility, high-risk obstetrics, and gynae endoscopy. She has also received the AIC RCOG Traveling Fellowship in Gynae Endoscopy in 2017 and received many other awards.
Yeah.
Also executive member of OXY. So let's move on to the session, your session. And could you please introduce Dr. Gokula Priya for the first topic, CTG, and proceed.
Thank you, Karpagambal. Our
Yes.
routine judges are in Mysore. So
No
I
problem.
requested Karpagambal to be the judge.
No
Okay,
problem. No
Karpagambal.
problem. Very
Thank
happy
you.
to be a part of this marathon CME, ma'am.
Another one thing also I forgot to tell. After the update and the panel, there will be a question that is for delegates. Whoever is answering first will be given a prize. Okay, that is just to encourage the delegates.
Yeah, sure.
Yes, Karpagambal, you proceed.
Good evening, everyone. I thank TNFOG, Sampath Kumari Madam, and all others for this opportunity. It's very, very happy to be a part of this marathon CME. And the most important thing is the topic that is very, very close to our heart, and we are all striving really hard to get down the maternal mortality rates. I welcome Dr. Gokula Priya. She's an MBBS student. She was an MBBS student from Keynote Medical College, college topper in the university exams in MBBS, and has gold medals to her credit. MD from also from Madras Medical College, and MRCOG from RCOG, Royal College of Obstetricians and Gynecologists in London. Her special interest at high risk obstetrics. Over to you, Dr. Gokula Priya. Dr. Gokula Priya.
Sahiti,
Dr. Gokula Priya is logged in.
I'm just checking, ma'am.
she said she's. My mic is not working. I log into another device. What about your slides? The slides are there. Okay. Her mic is not working, it seems.
Oh,
But she's
This
logging
because
in.
you will be given 12 minutes and 3 minutes questions will be asked by Dr. Karpambal. Okay. 12 minutes presentation. If Gokula Priya is not ready, if Hema is there, let her present.
yeah, let the second presenter can go ahead.
Dr.
She
Hema,
is there, no?
Dr. Hem, because it comes as doctor, we are not able to identify the names, ma'am. In the
Yes.
participants list, we are not able to identify
Hema,
the
if you are there, you can present.
no, Gokula Priya is ready with the slides, ma'am. It's just she's going to log in through another device, it seems.
Okay.
Okay.
I will find out. Dr. Gokula Priya,
Yeah, Dr. Gokula Priya. Can you hear us, ma?
you can hear, but we
I
cannot
think you're muted, ma.
rename your.
Yeah. Because it's very difficult to identify from the panelist list, participants list.
Game also.
Gokul Priya, ma'am, please start your video, ma'am.
Sagati, ask her to present, give the PPT to you.
In the meantime, if Dr. Hema is ready, she can go ahead actually.
Hmm.
I think Dr. Kartika Prabhu has also logged in.
She is logged in. She told that she may not be able to ask questions.
Yeah.
Amma, Gokula Priya and Hemalata, who is there?
Dr. Gokula Priya, பேர் தெரியுதுங்க madam இப்போ.
Ma'am, am I audible?
Yes,
ma'am.
audible.
Yeah,
Where
yeah.
is your PPT presentation?
You can share screen.
1 second.
Her video is not seen also, it's okay. Just the PPT.
Yeah, PP, share screen and start the presentation.
1 second. Ma'am. Just 1 second.
Radhika, in the meantime, Hema login பண்ணிருக்காளான்னு பாருமா.
மேடம் அவங்க ஜாயின் பண்றேன்னு சொன்னாங்க மேம். மொபைல்ல ஜாயின் பண்ண முடியல. she said to join up ட்ரை பண்றேன்னு இருக்காங்க மேம். டாக்டர் கோகுல பிரியா ஜாயின்.
மொபைல்ல எப்படி மேம் பிபிடி போடுவா அவ? சரி விடு.
ஜாயின் பண்றேன்னு இருக்காங்க மேம். இப்ப பேசின ஒரு நிமிஷம் முன்னாடி.
சரி.
ஓகே.
கோகுல பிரியா மேடம் ஜாயின் பண்ண முடியலன்னா உங்க பிபிடிய குரூப்ல போடுங்க மேம். நாங்க ஷேர் பண்றோம்.
Sahiti mail ID அமைச்சிருக்காங்க
Yes,
பாரு.
ma'am, I have shared my mail
Yes.
ID in chat box.
Yes.
Yeah, yeah.
So
Otherwise,
you can, so that you
Dr.
can
Gokula
share.
Priya, you can just put it in the group. We will share it.
Hema, ma'am.
இருக்காங்களா?
இதெல்லாம் முன்னாடியே
ஹேமா
வந்து
ma'am.
பார்த்திருக்கணும்ல கோகுல பிரியா and ஹேமா. ட்ரையல் இருந்ததுல 4:15க்கு ஓபன் பண்ணியாச்சு. Yours are also not. Shobha madam வெயிட் பண்ணிட்டு இருக்காங்கல்ல.
Hema ma'am has shared her slides, ma'am, so that I will share the slides. Can you
Yeah.
start the presentation, ma'am? Hema ma'am.
ஹேமாவும் கோகுல பிரியாவும் பதிலே சொல்ல மாட்டேன்றீங்களே, என்னப்பா ஆச்சு? இருக்கீங்களா இல்லையா?
இருக்காங்க போன் ஹேமா ஆன்லைன்ல கட்டு வேற
Necessarily based.
டாக்டர் ஹேமா டாக்டர் ஹேமா
Gokul Priya ma'am, I have received your slides, ma'am. You can start presentation. I will share on behalf of you, ma'am.
Okay.
Okay.
Yes, ma'am. You can tell next slide so that I will move the next slide.
Okay, ma'am. So very good evening to all the delegates.
Ma'am, kindly log out from the second device, ma'am. Only one device you need to log in, or else echo will be here.
Okay, ma'am. A very good evening to all the delegates, and I thank Dr. Usha madam for giving me this opportunity. Although it was I could not really prepare to my fullest ability because I was held up in 2 normal deliveries yesterday night. But I will try to do justice in the slides that I'm going to show. So previous slide, ma'am. Yeah, so this topic given to me was CTG and proceed. So next slide. So CTG is basically the most common fetal well-being assessment tool that is used both antenatally and intrapartum. So clinician must be confident in the CTG interpretation because the normal CTGs are fine, but when the deviations occur from normal, we have to be very careful in interpreting it in the right way and taking the right action instead of just jumping into conclusions. So we have to take the patient scenario on whole. The goal of the assessment should be to provide information that will guide the decision making, and CTG should be interpreted in the context of the entire clinical situation, including the gestational age, fetal growth, fetal movements, and progress and the stage of labor. Next slide. So we have CTGs done at 2 different stages. One is the antenatally, that is when the patient is not in labor, and also the other one that we do during the labor, that is the intrapartum CTG. The NICE guidelines gives us the guidelines only to follow that during intrapartum time. So the antenatal CTG but comes into play in most of our clinical practice to assess the fetal well-being, especially when the pregnancy is after 38 weeks of gestation. So it is usually done in the OPD, and the woman should be in the semi-reclined position. An electronic fetal monitor is used to record the fetal heart rate and the uterine activity. The recording should be conducted for at least 20 minutes or until we are satisfied with the trace. And the trace will be classified as normal or abnormal based on the 4 features of the CTG, namely the baseline heart rate, the baseline variability, the presence of accelerations or decelerations. Next slide. So coming to the indications for the antenatal or the antepartum CTG, this is usually done in high-risk pregnancies prior to or at admission time, or when they present to OPD with some symptoms, mainly during when the baby is an SGA baby, small for gestation age, with or without Doppler, with Doppler changes, and then the prolonged pregnancies beyond 40 weeks or 41 weeks of pregnancy, pregnancies wherein the AFA is less, there is oligohydramnios, hypertensive disease or diabetic disease in pregnancy who come with reduced fetal movement symptoms or any other imminent symptoms, and any case of APH that is presenting without contraction. Next slide. Next slide, ma'am.
Sahiti, next slide, ma.
Yeah, so coming to the intrapartum CTG, here the indications would be we offer a monitor with CTG. That is, we put in the continuous CTG monitoring for women in labor, especially when they have the high risk factors. Like suppose we are allowing a patient for a vaginal birth after a cesarean. So that is when they have a scarred uterus, previous cesarean birth or other full thickness uterine scar following myomectomy, all that. And if the patient is having any hypertensive disease needing medications, prolonged ruptured membranes, but women who are already in established labor at 24 hours after their membrane ruptured do not need CTG unless there are any other concerns. Any vaginal blood loss other than the suspected chorioamnitis or other than the normal show, suspected chorioamnitis or maternal sepsis, pre-existing diabetes type 1 or type 2, and also the gestational diabetes. So all high-risk pregnancies, we would like to monitor the patient with CTG. And the other risk factors would be, next slide, ma'am. Like if the baby is a fetal growth restricted baby, the SGA baby, small for gestation age babies, advanced gestation age, more than 42 weeks, if there is abnormality with the LICA status in either anhydramnios or polyhydramnios, or if the patient presents with reduced fetal movements in the 24 hours before the onset of contractions, if we are going to put the patient on syntocinon, and if there is meconium strain LICA. So these are other intrapartum events that will warrant a continuous CTG monitoring. So next slide. So what do we see in the CTG? So basically, there are 4 to 5 things that we see. The one is the contractions that is checked with the tokogram. And then we have the baseline fetal heart rate, the baseline variability, presence or absence of deceleration, and the characteristics of each deceleration if they are present, and also the presence of accelerations. So let's see that in detail with the next upcoming table. Next slide. So based on this table, so first of all, we like to see the baseline. So each of the characteristics that we are going to see will be classified as reassuring, non-reassuring, and abnormal. So baseline heart rate, the normal we would consider as 110 to 160 beats per minute, whereas non-reassuring would be 10 beats lower and 20 beats higher. That is 100 to 109 would be taken as reassuring, and 161 to 180 beats per minute of the baseline heart rate would be taken as non-reassuring. And what is said as abnormal is more than 180 or less than 100. So this is about the baseline heart rate. So how do we read that? We look at the stretch of the CTG that goes in a line, and whichever number it corresponds, that is based on the 110, 120, we take it as the baseline heart rate. So where the maximum portion of the CTG lies. Now coming to the baseline variability, so this reassuring is 5 to 25 beats per minute. Non-reassuring will be less than 5 beats per minute for 30 to 50 minutes, or more than 25 beats per minute for 15 to 25 minutes. When this less than 5 minutes exceeds for 50 minutes, or if the variability is more than 25 beats per minute and if it is sinusoidal, then we call it as abnormal. Coming to decelerations. So decelerations are not seen in reassuring except for the early and variable deceleration with no other concerning characters. If they're present, then it is okay for up to 90 minutes. But non-reassuring would be variable deceleration with concerning characteristics for more than 90 minutes, and also variable deceleration with any concerning characteristic in up to 50% of contractions for 30 minutes or more. Variable deceleration in over more than 50% of contractions, if they're seen even for 30 minutes, then we take it as a non-reassuring. And late deceleration in over 50% of contractions for less than 30 minutes with no maternal or fetal clinical risk factors like meconium staining or small for gestation age or oligohydramnios like that. But when it comes to abnormality in case of deceleration, so abnormal means variable deceleration with any concerning characters in more than 50% of contractions for more than 30 minutes, and late decelerations for more than 30 minutes, or any single deceleration or bradycardia that lasts for more than 3 minutes. This we take directly as abnormal. So accelerations may be or may not be present. They are not going to be judged during the intrapartum CTG assessment, although they may have some value during the antepartum CTG. When we see two accelerations, we presume that the baby's CNS and the heart system are intact. Coming to the opinion, how do we do? If all the three features are reassuring, we call the CTG as normal CTG. Whereas if there is one non-reassuring feature and two reassuring features, we call it as suspicious CTG. And we start conservative measures like putting the patient in the left lateral position, giving her some nasal oxygen, or if she is dehydrated, giving her some IV fluids. And also if the syntocinon drip is on, just slowing it down or stopping it, or if any vaginal prostaglandin pessary has been kept and which has caused the hyperstimulation, removing it. So such measures can be taken if the CTG is suspicious. And when it is abnormal, which is even one abnormal feature, or if there are two non-reassuring features, we call the CTG as pathological. And here again, we will start the conservative measures and maybe it would warrant further testing. So in this way, we can assess the CTG during the intrapartum period. And based on the finding and taking the patient situation in a whole, we need to take action for the patient to what would be the in the best interest of the baby and the mother. Thank you, ma'am.
Thank you, Dr. Goklapriya. That was a nice presentation on CTG. I just want you to explain the clinical relevance of CTG scenarios and maternal mortality. See, we all do CTG for the baby's sake. How do you think there are situations where CTG can be relevant for the mother's sake also? What are they called and what are the situations?
Yes, ma'am. If we are doing a CTG for a patient who's going for a trial of birth after a cesarean section, and we are seeing some bradycardia, and apparently we are reassuring ourselves saying that fine, the baby should be fine, but probably we're missing out on an early dehiscence or an early rupture, and eventually the patient can go in for internal bleeding and it can turn the events in a different way for the patient. So early diagnosis is very important to not only save the baby, but mainly to save the mother. So in that case, and the other scenario would be for an antepartum hemorrhage, like abruption patient, where a hypertensive patient probably we have induced, we feel the cervix is favorable and we are inducing her. And suddenly we see that her vitals, the BP is also coming down. And here in CTG also we have some fetal bradycardia or decelerations. And when we touch the abdomen, it is tense tender. Probably she has gone in for an abruption. This again, if ignored or if it has been monitored by some staff nurse who was not well trained to identify abruption, which is apparently a clinical diagnosis, this could be missed and it can go in for deterioration of the patient status as well as the cubital uterus and all the other complications. And the other one would be a patient with sepsis, probably a patient with fever. We are inducing the labor and the labor is progressing. And here again, when we see the tachycardia, we may presume it is due to the maternal temperature and all that. But if the sepsis is going beyond control and we are not able to pick it up at that stage and deliver her immediately and stabilize her, it can be one of the reasons for maternal morbidity and mortality, ma'am.
So what do you call these events as? Abruption, scar adhesion, scar rupture. What do you call these events as? For the baby, they are called as sentinel hypoxic events. So they are called as abruption. So you also identify fetal metal hemorrhage. It may not have any relevance for the mother, but it definitely has a relevance for the baby. And also, I always tell whenever you do a cesarean section, especially in late labor, deep transverse arrest, obviously that also increases the risk of angle bleed, risk of postpartum hemorrhage, traumatic postpartum hemorrhage. True. Even though you do it for saving the baby, but the risk of doing the procedure, especially that is the reason
second stage cesarean.
Yeah, second stage cesarean section carries more maternal risk. Okay, somehow you will be able to deliver the baby fine, but definitely there is also a risk of maternal morbidity and mortality in second stage cesarean sections, and also sometimes amniotic fluid embolism. So whenever you're doing a CTG and suddenly you rupture the membranes or the patient spontaneously rupture membranes, suddenly CTG till the time CTG could have been normal. So the maternal desaturation can also lead to abnormal CTG values. So these are called sentinel hypoxic events for the baby, but we have to be cautious that there are certain clues that can be picked up from the CTG, we can actually pick up and actually save the mother and the baby. So I just one more question. I just want you to, you were talking about maternal mortality. Have you heard about the 4 P's that we also always watch out when somebody who's in labor on postpartum? What are the 4 important P's that can lead that we are always worried about? We are
The
very-
P-
yeah, whenever any maternal patient goes to the ICU, the anesthetist or intensivist says as 4 P's.
Okay, first one definitely will be PPH, postpartum hemorrhage.
Correct.
Next would be pyrexia, sepsis.
Yes.
The
Yes.
puerperal sepsis. The next would be PAH. So that is hypertensive disease causing the complications like eclampsia or intracranial hemorrhage.
Pulmonary, yes.
Pulmonary embolism.
Yes. And last one, which you cannot diagnose. Sometimes you are missed in the antenatal period, and postnatally you come across. This is more prevalent. The peripartum cardiomyopathy. Many times peripartum cardiomyopathy is diagnosed in the 3rd trimester. Patient can be asymptomatic, and we can have this a type of dilated cardiomyopathy which can be diagnosed in the postnatal.
Peripartum cardiomyopathy. Yeah, okay.
So we always these 4 P's. No, you never forget. Whenever if you look at these 4 P's and start evaluating for them, you'll be able to find out. And most of the time you will be able to find out the cause and save the mother. These 4 P's are always spoken about by the intensivist whenever any antenatal or postnatal patient goes to the ICU for ICU care, intensive care. Thank you so much. Thank you, Dr.
Thank you very much.
Yeah. Thank you. Next, I call upon Dr.
Hema.
Dr. Hema.
Dr. Hema.
Yeah, Dr.
Good
Hema.
evening. Good evening. And
Yeah.
I'm here to present a topic about Partograph. So Partograph is nothing but it's a most important tool for health workers at any level of care to monitor the progress of labor and to take appropriate action. So it's nothing but a graphical recording of progress of labor about the condition of mother and the fetus. So it is a labor record and thus reduces the paperwork. So we need not to write the 4th hourly and every 2nd hourly notes. It's just a graphical representation of the progress of labor. So Partograph is applicable for only in the active stage of the first stage of labor, that is from cervical dilatation more than 4 centimeters to full cervical dilatation. But now recently active stage means after 6 centimeters. But the WHO Partograph is set in a way that it's only from 4 centimeter to full dilatation of cervix. So it is a simplified Partograph. So plotting, how to plot a Partograph. So first we will do identification data about the name of the mother, age, parity, time and date of admission, registration number, and time of rupture of membranes. So it is every
Slides are not moving. Hello? The slides are not moving.
slide. I am not sharing the slides.
You tell next slide, ma. Sahiti will.
Okay. Next slide.
Oh, ma'am, good evening.
So next slide, it's a simplified Partograph. So here we have all 3 sections of the Partograph and how to plot a Partograph. The first part is identification. Next slide. Is we should document the name of the patient, age, parity, date and time of admission, registration number, and time of rupture of membranes. Everything is given in the first part of the Partograph. Next slide. So after maternal data, we have to monitor the fetal condition or plot the fetal condition. So we have to count the fetal heart rate every 30 seconds, count for 1 full minute and immediately following uterine contraction. So it has to be monitored only immediately after uterine contraction. If there is fetal distress, there will be a dip in fetal heart rate less than 120 beats per minute, or if it is a tachycardia, 160 beats per minute. And if it is a primary healthcare center, and you have to arrange for a referral. So if it is a tertiary care center, we will go for intervention. And plotting a Partograph. So record the status of Record the status of membrane and amniotic fluid color every half hourly in a partograph, because initially it can be a clear lighter and after an hour it can be a meconium stained lighter. So we'll mark as if the membranes are intact, mark as I. If it is blood stained in case of abruption, you mark as B. And if it is a clear lighter, mark as C. And if it is meconium stained, mark as M. So use a sterile perineal pad to look for the color of lighter and status of membrane, and that is very, very important. Only if you're having a perineal pad, you can very well look at the color of the lighter. And next slide. Plotting a partograph. So in labor, so begin plotting in the active stage of labor, that is after 4 centimeter dilatation. That is cervical dilatation more than 4 centimeters and more than 2 contractions per 10 minutes. So always plot the initial finding in the alert line. That is very, very important. And we have to note the time. So when you're plotting the time at plotting at the alert line, you have to note the time. That is very important. And you repeat PV every 4 hours and plot the cervical dilatation in the alert line itself. In active phase, the cervical dilatation should be 1 or more than 1 centimeter. So in a primary, will have a 1 centimeter per hour, and in a multigravida, it's more than 1 centimeter, 1.5 to 2 centimeter per hour. So you have to mark the maternal condition also. You record the maternal pulse every half an hour and mark with a dot, and record maternal BP every 4 hours using a vertical arrow with the upper end signifying the systolic BP and lower end signifying the diastolic BP. Record temperature every 4 hours and note on the temperature chart. Next slide. So intervention, mention the dose, route, and time of administration of any drug and IV fluids which is given before delivery in the intervention column. Next slide. So how will you interpret a partograph? So if alert line is crossed, that is, if the plotting moves to the right of the alert line, it indicates abnormal labor, prolonged or obstructed labor. So we have to note the time when the alert line is crossed, and that is the time when you give a referral. If it is a primary healthcare center, and send the partograph with the patient. That is also very, very important step. Next slide. Crossing of the action line, that is the plot. If the plotting moves to the right of action line, it indicates the need for intervention. It indicates prolonged labor or obstructed labor. By the time the action line is crossed, the women should ideally have reached the referral unit for appropriate intervention to take place. Next slide. So what are all the indications for first referral unit or interpretation of partograph for timely referral? So one is, it depends upon the fetal condition and the maternal condition. If the fetal heart rate is less than 120 or more than 120, 160, it is fetal distress, and color of lighter. If it is meconium stained or blood stained amniotic fluid, when the cervical dilatation plotting crosses the alert line, that is moves towards the right side of the alert line, it indicates prolonged labor or obstructed labor. Contractions not increasing in duration, intensity, and frequency. That is less than 2 contractions lasting for less than 20 seconds in 10 minutes. So at least we have to have 2 contractions in 10 minutes. Next slide. So the key message is labor should be plotted on the partograph during the active stage when cervical dilatation is 4 centimeters or more, and the fetal heart rate, status of membrane and amniotic fluid, uterine contraction, pulse are recorded every half an hour. Cervical dilatation, BP and temperature are recorded every 4th hourly. And correctly filled partograph helps to identify any abnormality early, and it helps to decide the appropriate care or referral.
Thank you. Thank you. Okay, you have a case study.
So that's enough.
Okay. Is the presentation over, ma?
Over.
Okay. Now, Dr. Hema, I want to ask you, you have explained about the partograph But why didn't you take the latest labor care guide into consideration?
So I was thinking of only about the Partograph. That's why I didn't take.
But we have a labor care guide, which is like, so there are a lot of ifs and buts about it. All of us still
Okay.
have few things which we can agree and we cannot agree. But there is no mention of the latest WHO Partogram. The positives and negatives in our clinical practice has not been mentioned, because when you have a latest one, you're actually supposed to use that.
The
But,
latest one.
yeah, that is one thing. And another thing is, in Partogram, what can you actually incorporate so that the maternal parameters are given single? You have a maternal pulse BP. So what is the chart that is called as, where the warning signs of maternal signs and symptoms can be identified early?
Tachycardia, maternal tachycardia. If there is increase in BP or if there is if she is a hypertensive patient and if she is going in for abruption, there will be a increase. Always will mark a increase in BP. So BP pulse will be monitored in the Partograph.
The topic is maternal mortality, today's topic. So how can you think Partogram can be modified, or at least what can be incorporated so that the maternal parameters are also taken into consideration and the warning signals are picked up early?
Picked up early.
Have you heard of Meo's chart? Early obstetrics Meo's chart?
Heard of it.
Just go look about Meo's chart. It's
Yes,
very
madam.
useful chart where there are actually colored codes. If every obstetric
madam.
patient has this chart in her case sheet, and
Yes,
if we
ma'am.
mark it properly, along with the Partogram, we won't be missing anything from the abnormal from the baby and the mother. So that is
Yes,
a
ma'am.
very easy way of identifying. Even all the things are mentioned very beautifully in the obstetric early obstetric warning score chart. So when you talk about Partogram and all, so all these three things, CTG, we have a CTG sticker also. So where, you can actually, every CTG interpretation, you can, final conclusion of that CTG can be given as, what is it, whether it's reassuring, not reassuring, normal, suspicious, pathological. So, and what is the action that is taken. So it's called, actually, there are a lot of hospitals which have a CTG sticker to that. CTG with a sticker and Partogram and early obstetric warning Meo's chart. All these things should be a part of every case sheet for our antenatal patients. Don't miss out on anything. So in Partogram, you were mentioning about, action line alert 9. Yes. So what is the major thing that is different from, you mentioned about the onset of labor, the everything. So what is the major difference in the labor care guide, latest in the labor care guide? How different from the old Partogram?
Sure, we'll start plotting from 4 centimeter, but now the active phase of labor starts only from 6 centimeter dilatation.
Yes. And there are a lot of time that is given for each and every phase. We say 1 centimeter per minute, 1 centimeter per hour. It's not taken into consideration anymore. Actually, the patient can be in 5 centimeters for 6 hours. It can be in 6 centimeters for 5 hours. She can be in 4 centimeters for 3 hours, like that. So there are a lot of changes. So what it actually, have you read about it, Dr. Hema? Labor care guide?
I'm not fully read, but I have read it.
I think you should read it. It's an extremely nice concept, but the thing is incorporating, because we have had our age-old practice of, have our own, time-tested practices, which we are not able to give up, but over a period of time, I think things will change and we'll become more patient-friendly, and, we'll give more time for the, because it's very, very comprehensive and it's very nice, but I think that the change should begin from us. From the US.
But it can be practiced only in a tertiary care center. But when you are giving guidelines for a primary health care, we cannot ask them to wait for such a long period. Always they will have a old mindset.
Correct, but that's even not only in primary, even tertiary care center, old concept is still running in our minds. But what I would say is, just as we grow, I think whatever is suitable, whatever is feasible, I think you take up from the labor care guide. It's okay, and that is one of the most important thing we should look up at it. Warning charts. That's very, very important, because early obstetric warning scoring is very, very important, and it still has 3 colors: green, amber, and red. So whenever you just see the patient going into the amber only, you should pick it up. We should not let the patient go into the red and pick it up at that stage. Okay. Okay. Thank you so much, Dr. Hema. It was a nice presentation.
Thank you.
Congratulations to both of you. Well done.
Thank you.
Thank you, Karpakambal.
Thank you, ma'am.
Radhika, you can go to the second session.
Second session.
You can ask Usha madam to introduce Shobha madam. Anyway, Usha madam is not there, I think. I welcome
Madam,
Dr.
I'm there.
Shobha madam. Usha madam, irkingla?
Irka madam, irka.
Yes, you can introduce.
Okay, so now we have the expert advisor on reproductive and child health, Dr. Shobha, to address us on the maternal mortality rate. And she's the expert advisor for Tamil Nadu Health System Reform Project. She is the former director of Institute of Obstetrics and Gynecology, ECMO, Chennai. She has received Best Doctor Award twice from the government of Tamil Nadu for working towards maternal health. Her areas of interest are high-risk obstetrics and gynec malignancies. So we welcome you, madam, for your expert guidance to all of us.
Share. So good
Welcome,
evening.
Shobha madam.
Yeah, Sampath, somehow you push me into everything. And I must really thank you as well as Jayashree, because most of my talk she has covered in a very nice and crisp manner. Thanks, Jayashree, and your inputs are well taken. Would also tell you in the end what I think and go along with you. Okay, now we will go to the slide presentation. Next. Next. Next, move on.
Who is operating the slides?
Yeah, no, I have. Slow
Yes,
on.
ma'am.
You can come this side. You want to do it in mind? Yeah, fine. So this is a situation which we would not like to have. It is nightmare. Next slide. Giliye Panduma? Okay.
Sorry, ma'am, we cannot see the slides. actually.
Yeah. He's just working on it. He's working on through the next computer, the second computer, and he's sharing it.
Thank you.
Okay. Next slide. Yeah, Marla. Yes. But marriage.
ஏதோ ப்ராப்ளம் நினைக்கிறேன்.
இல்ல என்னோடதுலயே பண்ணிடு பரவாயில்லை நோ ப்ராப்ளம் ஓகே yes screen has come, it has to move now. Move next slide. Yes, so this is a situation which we would not like to have. Yes, next slide. So if you look at the maternal mortality in India, which is a South Asian countries, accounting for 16% of the maternal deaths globally, when you look at that. Next slide. So if you look at the South Asian countries, Sri Lanka has got an excellent primary level care. Their mortality is very low. Then comes Maldives, Bhutan, and then only India. So in the South Asian countries itself, we are ranking 4th place. Next slide. Now, when you look at in comparison global India, we should be feeling very proud, as Jayashree says, because we have achieved the SDG 3.1, because we have achieved the target well below the target we are there in maternal mortality. Next slide. So the current scenario, if you take up, that was what Jayashree was saying, that though we have reduced the maternal mortality, where we are actually, we were ranking next to Kerala in the states. Now we have pushed to the 5th place. Now this is according to the sample registration survey. So Andhra, Telangana, Maharashtra, they have gone to the front place after Kerala. And we have to look into the what are the challenges, what are the gaps we have, why we have been pushed back. Next. Now, let us look at some of the indicators to know what causes the maternal mortality, what are the factors that are playing, which period is very crucial, and things like that. So the first thing is, when you look at the antenatal period, it is 25%. Postnatal deaths form the majority for the maternal deaths. Now, this postnatal will be both intrapartum as well as the postpartum period, and antenatally reflecting more of a medical morbid conditions in the mother. Next. Now, when you look at we know that the MMR has some direct causes, some indirect causes. Of the direct causes, the foremost is hemorrhage, postpartum. The PIH, PPH will be fighting for the first place. Coming next is the heart disease, then comes the sepsis, then comes the abortion, and then the obstetric complications. So, having known this, we have developed a lot of interventions to tackle each of that. Still, we have a long way to go. Next. Now, coming to the place of death. Here you find the most of the deaths are happening only in the medical college. Now, that is because they have the trust that everything is available there, and they are being, dumped as a last resort, both from the lower institutions like PHC or DMS institutions, or from the private, sometimes even from the corporate, having spent lot of money for their treatment, and as a last resort for ventilatory support or anything else, they are being referred to a medical college. Next slide. Oh, this is the slide that shows how much of the deliveries are happening on the private side compared to government. And we do feel proud that on the government side, 58% are being done, whereas in the private, it is 42%. Next. Now look at this slide, which reflects that most of the mothers are booked. 92% booked mothers. Unbooked are only 8. Still, why these mothers booking? They have the antenatal visits, which number more than 5, even 10, and why they die. The quality of services, is that important? Next slide. So look at the age. When you look at the age, we know the RCH group means it is mostly the primi gravida, which belong to the 20 to 24. There the most of the deaths are happening. And then comes between the 25 to 29 age group. And this is the group, this 20% definitely can be approached, is the high maternal age. More than 35 is 6, 30 to 35 is 20%. And the last is, but not the least, we have to avoid adolescent pregnancy, which contributes to 4%. Next. So coming to the gravida also, because in the age group of 20 to 24, you have the maximum deaths. It explains that most of them are primi gravida, then comes the second gravida. But this group of 3 and above, definitely we can attack them with our family planning services. Next. So coming on to the type of deliveries, in Tamil Nadu, we have a very high percentage of C-section. And nowadays, people consider that C-section is not complicated. We know that there are anesthetic complications, there are surgical complications, and there are obstetric complications which can follow soon after the type of delivery. So the deaths are happening more in the cesarean delivery, which is 59 versus 41, the normal delivery. Next slide. Now, apart from all this, we are now coming across a situation like a non-obstetric cause contributing to 15%. This is something which is very terrifying because this factor is not being attended to when they come for the antenatal care, where suicide is amounting to suicidal deaths. where the mothers hang themselves or they take some drugs, poisoning, drowning, burns. All this is coming under this non-obstetric 15%. That is the reason we have now added Edinburgh scale in the Pygmy portal itself. And we have trained the staff nurses and the VHN to question the mother and whether she has a risk factor for that. Now, this is a very new tool which we have added on to the Pygmy portal itself. Next slide. Next slide. Yes. So coming on to the trends in maternal mortality ratio. If you look at this, from 2004 to 2014, if you look at the maternal mortality, there is a steep decline. Then leave alone the V shape, which is happening between 20 and 23, because that is the COVID period where more number of deaths happened. We know what is the reason. Again, if you chip off that and you connect that, then again there is a steep decline from 20 to 24 if you chip off the period of COVID. So let us see what has happened during that period, which has brought a decline in the maternal mortality. Next slide. So the magic word was CMOG. Now this World Health Organization and a committee was formed which looked into the maternal deaths, and National Health Mission also sat and discussed, and they brought out this comprehensive emergency medical, that is newborn care, maternal obstetric newborn care center. Now this CMOG center 24/7. Now the committee has recommended for a team of obstetricians, neonatologists, anesthetists. This team, and they strengthened the labor room and the operation theater so that when the mother is referred, in case she has to be taken up for C-section, so that was done, and it was strengthened with blood storage facilities, blood bank facilities. All this was included in the CMOG center. So this was a very good intervention which had been brought for the DMS and the DME institutions, and this has saved a lot of lives, which was responsible for the steep decline in the maternal mortality rate. So what all I have put is diagnostic facilities, and then I have put the blood storage, and also the ambulance, 108 ambulance. People call for the antenatal services. 25% when they are in labor, 108 services are being utilized to transport this mother to the nearest CMOG center. And the newborn ambulances had been established. Training to the staff nurses were given in newborn resuscitation, and the dropback schemes, JSSK, after delivery, the mothers were transported back to their homes, all free of cost. So this wonderful intervention had really brought down the maternal mortality rate. So that is the period. 2004, they got the GO. 2005, it was implemented. So it took almost 10 years for it was established in a phased manner. All the CMOG centers. Next slide. So as Jayashree said, what is the beautiful thing about Tamil Nadu? We have to get all the mothers into one bag, and that is the software where all the mothers are registered is the Pygmy. And RCH ID is a unique ID which is given to the mother and which is very useful in the tracking of this mother. Jayashree also pointed out that we have to make entry of the antenatal visits of the mother. What was her blood pressure? What was her hemoglobin? What date you have seen? What was the instruction you had given? Now, this is the most important step because the pregnant woman will visit a private clinician, will go to a nursing home set up of a logician, will come to a government facility, ultimately during the birth planning, where she goes. So we have to track all the details, and this is now going to be available in Pygmy 3.0. Now, how come all the poor mothers are, empowered with financial assistance? It is not only for the birth certification, but monetarily, they are being funded both by the government of India as well as by the state government, which is called as the co-branding. So this is the installment which they give during the periods, and it is a conditional benefit. What do you mean by conditional benefit? For the primary gravida and the second gravida, a cash benefit of 14,000 with a nutritional kit 2 times, which amounts to 2,000 rupees each. This conditionality, say suppose it is 4th month, she should have an early registration, she should have had a TD, she should have had her hemoglobin. So OGs, all this will be inclusive of the package. And say 4th month of delivery, she should have had an institutional delivery, she should have had a 0 dose for the immunization, she should have completed all 3, that is OPV, pentavalent, and hepatitis. So this conditionality was stressed upon to improve the indicators. This MRMBS, Muthulakshmi Reddy Maternal Benefit Scheme, co-branded with PMFY. This was a very good scheme and is there in Tamil Nadu. Next slide. Then comes the JSY. This is again a Government of India scheme which says we are very proud to say that 99 point, it is less than 0.1% of home deliveries now. This is the situation we have. So much of awareness is created that institutional deliveries are promoted, and we have a special incentive like 600 rupees in urban, 700 rupees in rural. So this is also yet another benefit the mother receives for the institutional delivery. Next slide. Next slide. Yes. Now, as I said, the initial downfall or the trend of maternal mortality came down because of the CMOM services, and the next decline, which you see if you nip off that V shape during the COVID, because COVID has taught us a lot of lessons as to how to communicate and how to establish or strengthen the health systems in the sub-center level. So likewise, mentoring concept came. This mentoring concept using the DMS and DME physicians in the management of high-risk pregnant mothers was very useful in the management of their disease, especially a real-time mentor where the district physicians used to travel to the block, and also virtual mentoring, which was done by the DME physicians. And every month they had a coordination, CMOM coordination meeting where the DPH, DMS and DME sit together along with the state MCHO officer, and they discuss the challenges, gaps, and the high-risk mothers, EDD mothers, how they have to be managed. Next slide. Now, as I said, the CMOM centers were established, and National Health Mission gives a liberal CMOM operational cost. Now, this cost is met with for their essential drugs, for their consumables, and also for their maintenance and repair charges, and is based on the load or the deliveries that are happening. Then we also know what are all the services which are available in the PHC. It is very easy for you to see. So I'm not going into that. But number Tamil Nadu, 5 antenatal visits are imparted. Okay. And you can see the nutritional kit, which has Avin Nei, which has a date, which has a nutrition protein powder, iron syrups, all, and a towel and a basket. So this is there in the nutritional kit. And let me tell you, which is also given to the HOB mother 2 times. Next slide. There are some 66 tests which are done at the PHC level. They have been given a semi-automatic analyzer where they do all the tests, And most important is now they do the thyroid screening there, they do the HbS-AG, and if the mother is found to be positive, they have been referred for a viral load to the DME institutions, and they get the medications at the DMS and DME institutions. So this is a new addition to the already available lab tests which are available in the block PHC. So what will happen if they go to the additional PHC? So that is where they have an LMIS, that is laboratory, yes, LIMS, Laboratory Information Management System. A hub and spoke model is created. So blood is drawn and it is being transported. They do the test. The mother need not come back to receive. It is given in their phone. Okay, it is shared in their phone. So this kind of facility is again done. And with the NHM is doing this, LIMS software they have developed facilitates the pregnant woman to see all her lab values. Next slide. Okay, we have developed the numbers, but quality of care is most important. Respectful maternity care is equally important. And then came Lakshya, which improves labor room as well as the operational theatre. We are very proud to say that 96 facilities have got certification for Lakshya standard. And in medical colleges, it is 30. In district hospitals, it is 30. Sub-district hospitals, 34. And the upgraded PHCs, it is 2. So this Lakshya is very important because all that what is Karpagam told about MEOS. See, maternal early warning signs and symptoms in the Lakshya case sheet is there every 15 minutes up to 2 hours. All they have to do is fill in those charts. The Lakshya case sheet has got everything with that. So quality is equally important than mere numbers. So that is also we have achieved. Next slide. Now, not only quality, and ongoing training is equally important. Dakshata training is happening, and DPH is arranging for the Singapore Health Foundation to come and give all the drills like shoulder dystocia, cord prolapse, PPH, sudden collapse in the mother. Apex Skill Lab, that also gave training to the urban logicians. They became the trainer of trainers to be imparting to the other logicians. So training is equally important to keep them skilled with the labor complications. Next slide. Now, I told you that HOB is something which we have to tackle. We have all the temporary and the permanent methods. You won't believe, the next slide will tell you that Tamil Nadu has achieved far and above in the permanent method, but not in the temporary method. It is spacing, which is very important and the need of hour, because the nutritional status improves and she has to limit the size because of economic issues. Now, this nobody realizes. That is why they go for unsafe abortions too. And the abortion services which are available in the DMS and DME institutions, please tell them whoever does not have financially, they cannot afford, these services are available. We do have an emergency pill. We have an MMA pill which is available free of cost. And what we are just saying is they have to come, they have to do the ultrasound. Now you all know that it is increased from 7 weeks to 9 weeks, where you can even locate whether this is a scar pregnancy or an ectopic pregnancy. So you know that it is only intrauterine and go ahead with a medical abortion. And once they are completed, then after 2 weeks, a check ultrasound is done. All these services are available in a block PHC. It is available in the DMS institutions, the sub-district hospitals, in the medical colleges, it is available. Now, why they don't approach? Because of the confidentiality. Now, we are speaking to the logicians that it has to be maintained, but whether they are married, not married, status is not important. we have to maintain the confidentiality, improve our services so that unsafe abortions are coming down. And the PCPNDD Act is strictly implemented. Recently also, they have found out some people and they have arrested. So the strict implementation is going on as per the PCPNDD Act. And also we know that the district medical board has to be formed. Now this medical board is available in 26 districts. Extended period of gestation, like more than 24 weeks, you want to terminate on the grounds that the baby has a congenital malformation, which is a lethal anatomy, and that is decided by the medical board. And this also is available in a medical college. Here again, I would like to say that Implanon in a pilot mode is being done. Now, this subdermal implant, the TOT of trainers were sent from Dharmapuri, from KGH, and they have started in IOG as well as KGH and in Dharmapuri. And the subcutaneous injection of Antara. Okay, so this also is being piloted in Ramnath Medical College. So these are very costly and it is being piloted. And we should also tell that this is available and is done as temporary method, as a post-abortal method, as soon after delivery. So this is something new that is coming on to the family welfare service as a family welfare service. And the financial assistance, 600 rupees for a tubectomy. For failure, they give 30,000. In eventuality of a death, usually the mother dies due to other causes, not because of family planning, sterilization alone. Still, we give them on the grounds of, the mother has died, 2 lakhs compensation is given. And for intrauterine contraceptive device, 300 rupees is given to the woman as a incentive. Next. So when you look at this slide, this is what I'm saying. The total sterilization is far and above. Okay, but look at the temporary methods. Of the temporary methods, if you consider the PPIUCD 89.9, what happens is the mother inserts because of the conditionality of financial assistance and she goes outside and she removes that. Now, this is where our role as an obstetrician. We know that they cannot say no. So they have to have this IUCD. It is good for her. And please don't remove that. And also tell her in case of C-sections, it is better to have it in place so that the intervals 3 years is achieved. They go and remove that. That is the reason the PPIUCD, though here the figure is there, percentage is high, but still we are having lot of problems, unwanted pregnancies. And the second thing is very disheartening to see that the oral pills and condoms, the usage of that is in single digit. So much so that we have to really do counseling as even before marriage, they have to start this as to when they have to have their family. Next slide. So this is as for the NH5 survey. If you say we have achieved far and above. So yes, next slide. Now coming on to the nutritional aspects. What are all the nutritional aspects the government is doing for a mother who has got less weight? So the State Planning Commission, what it did, it gave a financial assistance in certain districts where they have taken MMR is high, the very large number of growth restricted babies are there, IMR is very high. So those districts were prioritized. And in the block, all the mothers were given assistance. And this is the time and period for which the assistance was given. This is given up to when the child is almost 2 years old. Up they receive almost 5,000 rupees in addition in the certain months. Like for example, 18 to 20, first to the pregnant woman. And of course, there again, the mother has to gain weight. Okay, that is very important with the conditionality. then again 26 weeks, then again at 37 to 38 weeks. Then later 500 rupees 4 times is after the child is born. The child is being brought and they do the growth chart, they plot for the baby, and then only they give this money. Slide. So the ICDS is also giving 1 kilo nutritional powder. This is apart from the nutritional kit which they also receive. Next. Now, what we have for the high-risk pregnancies, how they are being managed. High-risk pregnancies, be it for anemia, we do employ the Anemia Mukt Bharat guidelines, where mild, moderate, severe cases, and we are well aware of the intravenous supply of ferrous sulfate, which is given, and in some of the districts, ferricium is also being piloted. Magnesium sulfate regimen for eclampsia, antihypertensive means here we prefer only labetalol, aspirin prophylaxis in case of the scoring and when the scoring is high, steroids for preterm labor, pregnancy and heart team. This is very new because we found that the heart disease complicating pregnancy were on the rise. We all think that it is only the rheumatic. But now we know that congenital heart diseases, because they do get pregnant, and surgically corrected heart diseases also get pregnant, that this has to be attended. So a pregnancy heart team means OGCN, cardiologists, anesthetists discuss the management at term. Then we have WhatsApp group. This WhatsApp group will have in the districts, it will have the private OGCNs, it will have all the persons who are dealing with the high-risk mothers, the groups are being formed and high-risk mother tracking is done. The state level in DMS, we have a PICME 102 call center where the high-risk mothers near EDD, 3 months prior EDD, these mothers are called at random and they are checked whether they have done their hemoglobin, whether OGCT was done, whether they know what is their blood pressure, whether they are on labetalol and they are taking. So this PICME, this is a dashboard indicator for our Chief Minister too. So these sort of guidelines have also been developed. Next. Now, audit was something even Jayashree was speaking about. This is something very close to my heart. Now, this gives us lot of lessons to be learned. But the thing is, we know we don't do it wanted. It happens somehow. And this is done at multiple levels that people do grumble and feel very bad about it. That it is done at a collectorate level, it is done at a DD office level, it is done at a state level. As she says, anonymity has to be maintained so that they come out with open as to really what has happened, which will, and we have to learn if we are wise from others' mistakes and not from our own mistakes. Now we have started stillbirth audit, but here we are including after 5 months and not after 6 or 8 months. And IUD, stillbirth, all the cases are enrolled into that. We have started doing this audit in DME and DMS institutions. And C-section audit also we are. This all not only talks about the Robson's classification, which we all know the types where they are mostly encountered. We also know that induction of labor and fetal distress forms a main part for the primary cesarean section. And if you look at the primary cesarean section rate, I think we need to look at that and we can optimize the cesarean section. Not only that, what is the other thing which we can learn and share is doing a near miss audit. This is equally important and very nice. What are the things which the facility has done to save the mother so that it will become a lesson for the others? So the lessons learned are what we have to identify the gaps, address the lacunae, identify all the delays, and we do, I should say that Tamil Nadu is not having any punitive action on the person when they are having a maternal death. But one should have an accountability for that. that moral responsibility, working consciously, definitely should be there. Next slide. So how we have to move forward? Periodic training we have to keep on because the staff nurses keep changing. The medical officers move to the post-graduation, and also there will be change from the OGCN side too. And what the audit is like some FM forensic medicine, it definitely gives us some mindful lessons which we have to do and implement for course correction. Communicating to the patients with warning signs and symptoms. This is very, very important. We have to talk, tell them to report early. For seizure varudhuna, they think that pay pudichirukku kondu poi mantravadita poi vepal adikira kalamu ippom irukku. This situation should change. Awareness on the health welfare benefit schemes to the public. Private hospitals should work in coordination with the government facilities. Birth planning must be done for every mother. And Karpagambal was saying about labor care guide. Yes, midwives definitely, when they are roped in, definitely we can reduce the C-section. We can save a lot of mothers, and we can say that high-risk cases, the specialists would act. So we should say that we have to put an end
Thank you,
because
Sultan.
all maternal deaths are preventable. Thank you.
Shobha madam, thank you. Wonderful talk. Private and government will work together and we will reduce the MMR. Sure.
Yeah.
Thank you, madam. Thank you so much.
Yeah. Thank you for allowing an extra 10 minutes. Sorry, Sampath, I took the entire half an hour time.
No
Sorry.
problem, madam. Everyone should know what the government is doing. Definitely. Thank you so much for the wonderful elaborate talk. Okay, madam. Thank you.
Thank you, madam.
Thank you, Pa. Thank you.
We all learned a lot. Behind the scenes, so many things going on, ma'am. And thank you so much for the information and a wonderful talk, ma'am.
Thank you, Pa. Thank you, team.
Thank you, ma'am. Sahiti,
Yes,
can you please
ma'am.
put the question from ma'am's talk?
Yes, ma'am. Okay. Shall I launch the question, ma'am?
Yes. Please. How many tests done in antenatal tests done in the antenatal? It includes the investigations. So how many investigations are done in antenatal visits?
Yeah, so though we have 66, the basic things are they can do a hemoglobin. Yes.
Ma'am, this is for the delegates, ma'am.
Oh, yeah. Okay, sorry.
Okay,
Okay.
ma'am. Thank you.
I just thought that.
It's okay. Anyway, we will check whether they're all listening. So,
Yeah, that's good. Okay.
please launch the question again. Sahiti,
Yes, ma'am. Shall I launch the question again, ma'am?
no problem. Launch the question again. Whoever is, writing first will get choosing the answer first will get the prize. How many tests done in the antenatal visit? A 66, B 55, C 44, and D 33. So hosts and panelists cannot vote. 30 seconds.
Yeah, last 5 seconds. Time up.
Thank you. Thank you, Sahiti. So that was a information-packed session. Very important day to day. Next, we move on to the session 3, panel discussion on case scenarios in MMR. I welcome Usha ma'am and Manoharmani ma'am, who is the president of Kovai Obs and Gynae Society, well known to all of us. Dr. Manoharmani ma'am is a professor and HOD of Department of Obs and Gynae, Coimbatore Medical College Hospital, Coimbatore. And she has received Johnston Medal and Best Outgoing Student from Madras Medical College.
Thank you for the opportunity, Pa. Yeah.
Thank you,
Thank
ma'am.
you.
Next, I welcome Dr. E.S. Usha, whom we all know. She is a senior fetal medicine specialist and consultant in high-risk obstetrics She has more than 30 years of experience at Lotus Multi-Specialty Hospital, and she's the past president of Erode Obstetrics Society, ISUOG and FOXC, the member and faculty in National Fetal Medicine Obstetrics Conference and workshops. And she conducts regular training programs for ultrasound and colposcopy. And she's a volunteer.
Thank you, Dr. Radhika. Yeah.
Thank you. And the panelists are Karpagam ma'am, Dr. Karpagam ma'am, who's done her UG and DGO from Stanley Medical College and MD from Madras Medical College. She's received the Best Doctor Award in the year 2018 and published papers in various journals.
Thank you, madam.
Just Iris Obstetrics. And madam, can you please,
Thank you, madam.
Manonmani ma'am, can you please introduce Dr. Lalita? Dr. Lalita? Okay. I'll go on. Dr. Lalita is the Associate Professor of Obs and Gynae.
Yeah.
Fetal Medicine Specialist. From PSC Hospitals, Coimbatore. And she's a member of ISUOG, RCOG, and FOXC, elected member of International Representative Council of AAC, RCOG, South Zone, peer reviewer of international journals, and certified instructor for ALSO, also, and RCOG Part 3 examiner, special interest on high-risk obstetrics, first trimester anomaly scan, fetal echocardiography. And then Dr. Sumati ma'am, welcome Sumati ma'am, who's done her MBBS at Tirunelveli Medical College, and she's received the Vadamalayan Endowment Prize for securing university rank in medicine in 1988, and she's done her DGO from Madras Medical College and MD from MMC Chennai. She's a former professor in HOD Department of Obs and Gynae, Government Rajaji Hospital, Madurai, and she's 30 years of service. And
thank you for the opportunity, and I thank Ramani Devi madam and Sampath Kumari madam.
Thank you, ma'am. We are delighted to join you, ma'am. This panel, the panel discussion. Manonmani ma'am.
Right? Yeah. Shall I share the slides?
Yes, ma'am, please.
Actually, net connection is not going and coming. Can you all try sharing it properly?
Or shall I ask to share, ma'am? Manonmani ma'am.
Hello.
Yes. Hello.
Yeah.
Madam, am I audible, ma'am?
Yes, ma'am.
Yes.
Slides terida.
Terida, madam.
Okay. 1 minute.
Lalita. I'll call Lalita ma'am.
All panelists available?
Yeah. Lalita ma'am has
Hello,
joined.
I'm there, Dr. Radhika.
Okay.
1 minute. I'll start from the first slide. Just give me a minute, yeah. My co-moderator Usha ma'am. For the maternal mortality panel discussion on missing links. Actually, I have been all hearing what the steps that is being taken by government of Tamil Nadu for reducing mortality. So, a few real cases. So, we'll have the discussion and opinion from our panelists where the cases went out of our hand. So, to start with,
I will finish this.
Yes, ma'am.
Hello.
Yes, ma'am.
Am I audible?
Slides are not seen. Audible. Slides not seen.
Net connection.
Madam, இல்லைன்னா groupல போட்டீங்கன்னா they will project the slides.
இல்ல போன்ல
இல்ல groupல போட்டு விட்டுருங்க.
கற்பகம் மேம்
I got it, ma'am.
1 minute. ஓகே அப்ப நீங்க ப்ரொஜெக்ட் பண்றீங்களா? இல்ல ஆக்சுவலி நெட் கனெக்ஷன் ப்ராப்ளமா இருக்கீங்க. I am in Mysore.
Madam, am I audible?
Audible. 1 minute. Actually, the net is proper means will come. The problem is
சாகித்யக்கு அனுப்பிட்டேன் மேம். அவங்க வேணா ஷேர் பண்ணட்டுமா?
இல்ல மேடம், sharing is not a
இல்ல மேடம்,
problem.
ஸ்லைடு
Net
வந்தா
issue,
உங்களோட
connectivity
ஸ்பீச் கம்மியாகுது.
ஓகே.
over here. Okay. Sir, அப்போ I think in the Karpagam ma'am can have show.
Yes,
Karpagam
madam.
is having. But yeah. I think I had the slides, Alam.
Okay.
I think I sent. Yeah, you can share it from your end. Or shall I send to Sa?
I'm
Priya?
having the slides, ma'am. I'll share.
சாகித்ரி மேம்.
Okay. Second slide.
First slide.
Slide show ponga.
Yeah,
Ma'am.
it's in slideshow only, ma'am.
Next one.
Case 1 projector இருக்கு மேடம்.
Okay.
நீங்க
No, the
previous
first
slide.
previous slide.
Ah.
Okay. So she is 28-year-old. Second gravida. She delivered by vaginal delivery at a PHC on April 24. I think Sagit, it has come out in the last slide.
Second. Sagitri, first case 1 slide. Yeah.
Oh, it's okay. She has delivered by normal vaginal delivery at a PHC. Since she had excessive bleeding PV on first day with a hemoglobin of 6.6. She was referred to tertiary care hospital. Her hemoglobin on admission was 6.6. Next slide. Next. இல்ல ரொம்ப பின்னாடி வந்துருச்சுப்பா.
இல்ல மேடம், கரெக்ட்டா தான் இருக்கு. No evidence of
So on examination, there was no message. Vagina cervix healthy. An ultrasound showed no evidence of RPOC with endometrial thickness of 4 mm. Since the hemoglobin was 6.6, anemia correction was done with a blood transfusion and discharged on 10th postnatal day with a hemoglobin of 10 grams. Was admitted 3 days later. Next slide. Next slide, pa. But on readmission, it showed hypervascular RPOC, planned for manual vacuum aspiration, but patient got absconded. With this history, can I have the panelist opinion where the problem started with this for this patient when she was admitted? Sumati ma'am.
Actually, the first at the time of the delivery, whether she had any problem or any excessive bleeding at that time itself, there was a sudden fall in hemoglobin to 6.6. So what was her initial hemoglobin and how much time she was admitted there in the PHC, and how they have managed at that point. Why there is a sudden fall of hemoglobin? At that time itself, they would have referred the patient. Probably they should not wait till after the 24 hours or even the next day only they referred, it seems.
Yes,
So
madam.
immediately.
Yes, as you correctly pointed out, patient had excessive bleeding PV and she was sort of anemic side, and she had a bleeding out of proportion, and she was kept in the PHC for a day, and then she was referred because the hemoglobin the next day showed 6.6. So the first point missing link is when the late referral, and the hemoglobin was blood loss was not picked up, and they would manage atonic PPH, whatever the drug available in the PHC. So that was the first is late referral. But on admission, she was given blood transfusion and she was ultrasound done, showed no RPOC, no bleeding. So she was discharged. And again, she got readmitted and she was planned for MVA, but she absconded because for the family problem. And then we sent, as Madam was, Shobha Madam was discussing already, we sent in the WhatsApp messages and she was brought back by the VHN. She was went and met by VHN at home, but she was not willing to come to the medical college. Again, they have been going on convincing her. So she was, but then again she had a bleeding. So she got readmitted with the bleeding PV on 17th day in a different hospital. Their ultrasound. So again, she was referred back to CMC for MRI the postnatal day. So wherever had bleeding, blood transfusion was given. On admission, her vitals were stable. Her abdomen was soft and vaginal examination was open and bleeding P was present. Next slide. Next. So this history, I think Karpaka ma'am, where is the problem from this time, from the discharge and readmission? This is the all cases, mortality cases. So discussion is on where and all it went out of our hand.
This
She admitted
particular
on
patient,
readmitted and she had bleeding. So where is the problem? If you had intervened at that time, is yeah, Dr.
when she got readmitted on the 13th day, when she got absconded, at that time
Yeah.
itself, somehow she should have been
Yes.
brought back. Of course, they have tried. And she has gone to different places, again to another private, I don't know, some other hospital. And
Yes.
again, she is brought back here. So all this amount of blood loss, she is going to become more and more anemic. So this particular patient, she requires more motivation to come to the tertiary care center for treatment. And it was a hypervascular RPOC.
Yeah, yes,
So you
your
must
point
also
correctly
think
said.
in
It's the
terms
second
of
point where the
when you plan for the MBA, it was hypervascular RPOC. So chances of AV malformation is definitely there. We also had 2 cases in Tucci.
yeah, yes, sir, that
AV
was yeah,
malformation.
so you correctly said. This is again the first scan was empty, and second again she had hypervascular RPOC.
Yes. That was the time she absconded.
So she got
and then she has
admitted.
come back.
As
She
you
went
rightly
to
pointed
another
out, she
hospital.
absconded.
So multiple, I mean, not referrals.
Yeah.
Patient has gone back and come back again and to another hospital. All this increases the morbidity and mortality for this patient.
So from day 1 referral, against the final day, she got admitted on 25th day. So these many
Yes.
days, absconding and again readmitting to another hospital. From there, again referral. So this many days have been lost. So on admission, again, third
admission. So in the third admission,
No.
the
Again, the
AV
SARPOS increased to
malformation.
4.4 to 2.4 centimeter. Yeah,
Yes.
it is third admission. AV internal vascularity noted with endometrial cavity. Possibility of correlated placental tissue. Actually, we discussed with the radiologists at that time. They said it is only RPOC. It doesn't look like AV malformation. And next slide. Next. Sagiti, next slide. Yeah. So since she was bleeding, there was again RPOC. It has been there for almost 10 days. So she shifted to emergency OT with 2 units of blood for MVA. So she was taken at minimal periplasm tissue removed at the next.
There was, Madam, after this procedure, there wasn't much bleeding.
Next slide. No, actually, on the table, she had 250 ml of blood loss with a drop in BP. And she was tachycardia also. So it was converted to GA. And again, all the uterotonics were given, tranexamic acid given, bleeding stopped, and second unit of blood on flow. But then inotropes were started because the BP was falling down. So it was shifted to ICU with the ventilator support. Next. Because noradrenaline started because it was supposed to be a prolonged bleeding and there would be a sepsis added on. So she was on mechanical ventilation and sedated paralyzed mode with the BP 160. And then pulse rate was 105, SpO2 was 99 with the VT. And then 900 ml of clear urine drain and urobag. Patient was on mechanical ventilation. Again, she was for 2 hours. She was maintained status quo. Next slide. Next. Next.
So she never improved
stepped up
post-operatively.
and her BP picked up to
Ma'am,
This in ICU. And next slide. Next. Dr. Gauri.
yes, ma'am.
So again, refractory hypertension started on vasopressin, but she didn't improve. So what do you think this is the cause for this collapse? Apart from she had a bleeding and she didn't improve.
This is a major cause, ma'am.
Yeah, in this case, yes.
Usually, yes, in this case, ma'am. And initially, because she missed the 2 or 3, many days she's moved to different hospitals. She didn't receive antibiotics. I don't know whether she got the antibiotics, but usually we give 48 hours, 72 hours antibiotics, and then we proceed to the with the EVA and the removal. But then I have a doubt, ma'am. Why with 250 ml, how could the blood pressure drop so low? So it must be only sepsis, ma'am, or perforation.
She was yes.
Why hysterectomy was deferred? Why?
Madam, hysterectomy actually Sumativana question. Well, very good question. Actually, it was a 3 to 4 cm RPOC. So they thought it will come easily. But suddenly she had
No,
measured
initially in the
bleeding.
scan they have told that there was no evidence of RPOC or like that they have committed. You're told initially
Yes.
it was. So then once again she has not improved and she is once again she is having a bleeding and also once again there is an RPOC. Instead of going for EVA, better if there is a fall of BP at the time of procedure, at least you would have proceeded for a hysterectomy. Then that is my opinion. If during the procedure in the theater, so why can't we go for a hysterectomy? At least the source you are thinking that it is the sepsis. So better if you have proceeded with a hysterectomy at that time itself, there is any possibility the patient would have survived or not.
The perforation, ma'am.
Yes, ma'am. No perforation. As Madam correctly said, this is the point discussed in the maternity VC. So instead of when she was admitted second time, when she absconded, that time she would have undergone hysterectomy, or at least third time when she got admitted, instead of going in for MBA, we should have straight gone in for hysterectomy with all the supports. So this is the fourth time she missed the net and she died. And actually, she didn't have any fever or no hypotension. But then sepsis also added on. And another thing is, again, we retrospectively discussed with radiologists. Could that be because they said it is not AV malformation in the second admission. So we went and discussed again, could this be a AV malformation? Did we miss that? If it, then we would not have gone and touched the patient on third admission. So this is the point learned in this case is, Lalita, can you please summarize the points of discussion? Lalita on
this patient. Yeah. Can you hear me?
Yes.
Yes. Yes, Lalita.
Okay.
So points
this was
where
the case with secondary.
Lalita, not audible. Hello?
Hello?
Yes, yeah. Audible.
So the points in this case is like she had recurrent admissions. So what I feel is this is not looking like an AV malformation, and whatever was there inside must have been bleeding and clots. It doesn't look like a septic shock to me. It looks like secondary PPH, and then like as Madam said, this was a real straightforward candidate for a hysterectomy after a second admission.
Yes. So this is the lesson learned from this case. So early referral and antenatal hemoglobin improvement and little bit referral after 24 hours. And first admission, she was treated, but then when she got admitted second time, procedure should have been done so that she didn't get absconded. And when she got readmitted in another hospital, all this history should have been like consolidated and prevented this patient's death. So this is a real case what we had. So, and then actually we had recent past 5 days back, there is a post-abortal bleeding and it was found to be AV malformation. We did uterine artery embolization with our intervention radiologist. So she is okay now. So now after that, we had one more cases of secondary PPH from periphery with a small bit of with the placental tissues retained. So we straight away, because of these patients' experience, we went ahead with the hysterectomy and it's okay now. So this patient, nowadays with the atonic PPS has come down and patients are dying because of either retained or sometimes with the sepsis. So this is the lesson learned from this maternal death. And we'll proceed to the second case. Next slide. Next. Sagiti, okay. So she is a 24-year-old primey referred from peripheral hospital as a case of primey with the EDD of 5 weeks, 3 days with a bilirubin 2.4 with a thrombocytopenia of platelet 1.1 lakhs. For further management, initially she was admitted in a private hospital where she was diagnosed as jaundice with a thrombocytopenia and referred to district hospital. She is a known case of thyroid and thyroxine for since 12 weeks of gestation. 12. Start with a question from you. So, what are the high risk this patient is having? So, Lalitha.
This patient has increased, she has jaundice and thrombocytopenia. So elevated liver enzymes and was her BP normal?
BP is normal, yes. BP is 90, 60 and 160 only. So BP is normal.
So anyway, whenever there is elevated liver enzymes and low platelet, we always think of HELP. So, I think, so we'll see what she has.
So she was again referred and admitted in tertiary care with a history of vomiting and dizziness, sweating, BP of 90-60, pulse rate 140, SpO2 99%, and with a 700 ml of urine.
How much
on examination? She was
ma'am?
enzyme previous slide per 7 point previous slide ponga Sagiti previous slide.
Total bilirubin was 7.4, but the liver enzymes report illa
adula varala. We have done. So next slide. So it's 25 weeks and 3 days with a normal
PT, APTT, and INR and other liver enzymes.
Sagiti, next slide. Hello, am I audible?
Yes, ma'am.
Yes.
Am I audible? The next slide, please.
Yes.
Yeah. Next slide. Okay, so you are drowsy, responding to oral commands. Ecchymosis. Hello. Am I audible?
Yes, ma'am. Previous slide.
Yes,
you're
audible.
Yes, ma'am, you're audible, but I think we need the previous slides, Agiti. This is the investigation slide, ma'am. Ecchymosis. Madam?
She was having ecchymosis and a small abrasion and periphery cold and
small abrasion, 1 centimeter right cheek, periphery cold, icterus, no pale edema. Next slide. Next.
Sahiti?
Yeah.
Yes, ma'am, I'm here only, ma'am.
Yeah. RBS was 49 milligrams per cent, and she was resuscitated with 25% dextrose. Hematocrit, hemoglobin and platelet was 1.7 platelet, WBC 7,500, urea 16, creatinine 0.7, total bilirubin 8.5, direct is 4.2, SGOT 1,600, SGPT 545, ALP 166, LDH is more than 1,200, sodium potassium 138 and 3.8, BTCT normal. Ultrasound showed single live fetus 24 weeks with maternal organs normal, maternal portal vein, normal portal vein Doppler. Next, Agiti.
Liver, they have told any ultrasound.
Maternal organs normal, madam. Liver normal. So she was treated with the MG opinion. We treated her with antibiotics and liver supports along with the MG opinion. So due to early onset of spontaneous labor, on 10 hours of admission, along with the transfusion of 4 units of FFP and 4 units cryo, she delivered a red-born boy baby of 860 grams. And 4 more units of FFP and 4 units of cryo transfused post-expulsion because of the altered liver parameters. And prophylactic PPH measures were taken with tablet meso and SR cannula was applied. Next. So 6 hours postpartum, again our hemoglobin is 7.7 with platelet of 27,000. 2 units of packed cell, 6 units of platelet, 6 unit FFP, 6 unit cryo massive protocol given. And renal parameters started elevating with urea of 19 and creatinine of 1.4. Again, our bilirubin also started increasing from 11 to 11.6, and the liver enzymes again in the same higher range. So, what is the problem we have, Dr. Karpagam or
All these parameters looks like acute fatty liver of pregnancy.
Yes.
Especially she is having a hypoglycemia.
Yeah.
One of the clinching factors which we have repeatedly noted in acute fatty liver of pregnancy.
Again, male fetus, all altered, all parameters changed, and repeated hyperglycemia was going, and she had went in for even the abrasions, and wherever we started IV and taken blood, she had all ecchymatics.
And her bilirubin was also raised.
So completely.
And usually the mortality rate in these cases is very high.
Yeah.
So far we have had bad experience with acute fatty liver.
Plasmapheresis, any role of plasmapheresis?
Next slide.
So what is it? Maybe it is going on. Bilirubin is getting elevated.
We discussed actually. Fibrinogen also 100, madam. So in spite of component transfusion, INRs were 3.8. She was conscious, irritable, and obeying to oral comments. And again, MG opinion obtained. They said it is hepatic encephalopathy for which plasmapheresis was advised because she had elevated bilirubin and liver enzymes also elevated with elevated INR. Actually, all the liver workup, hepatitis A, E, C negative, and we thought of even lepto and dengue. It was done negative. Ammonia 77 increased. Next. So actually, plasmapheresis we discussed whether we can give to save the patient. And then plasmapheresis done along with the 12 units of FFP. It was discussed and it was also done. But she developed again tachycardia for which adenosine was given to revert the rhythm. Next. So I think nowadays, instead of, apart from our obstetric work, we have become intensivist, with all these ICU cases. And since she was, her consciousness level was deteriorating, CT brain was taken because we thought, could there be a bleed in the brain? But there was no abnormality detected. And again, she was intubated with a GCS of 715. Post-intubation, patient had persistent tachycardia with a fluctuating BP. So noradrenaline infusion started. And the third postnatally, she went in for arrest and she couldn't be revived. So, Dr. Gauri, what are the lessons we could, Radhika Gauri, what are the lessons we learned from this case? This is a cause of death.
Yes, ma'am. So, when we have hyperbilirubinemia and sudden deterioration, we should always think about fatty liver. As Dr. Lalita said, help is also an important thing we should consider. But because the BP is normal and the enzymes are rising, if it goes above like thousands, you should always remember acute fatty liver and quickly should terminate the pregnancy. In this case, we did do that, but sometimes it is difficult to change the course.
Yeah.
Yeah.
Yes, yes, ma'am. So this case, this is what the problem. Actually, by the time she got admitted, her bilirubin has gone up to more than 11. So we could, we did whatever is best possible for us, but then we were not able to make the patient survive. So could there?
But actually, Mano, it is even bilirubin it is 11 point only. You have told, even 23 it is gone, and we have done plasmapheresis at GRH Madurai, and the patient was saved. But even the patient stay at the hospital, the duration of stay was
Madam, or 10 days.
10 days.
Actually,
so probably would have started earlier plasmapheresis. Any
actually, on the day of admission, within 6 hours, she went into labor, 6 to 12 hours, delivered within 24 hours. Fourth day, we started plasmapheresis. Actually, we had one more AFLP 2 weeks back. So again, she was with the liver support and all the supports and over one cycle of plasmapheresis we did, she recovered. So this
Yes.
patient, she recovered.
The difference that is even with the high bilirubin, even plasmapheresis, the patient can recover. But this patient is very acute and sudden rapid progression towards mortality.
So the point we would like to highlight in this case is, if there is jaundice, not only help, we have to think of AFLP, and aggressive intervention would help the patient. Immediate and aggressive intervention may make the patient survive. Lalita, any case you have seen?
And actually, we've had mortality with liver dysfunction in such cases. And normally, when there's liver dysfunction, we have one we have this coagulopathies, the other side we have hypoglycemia. Both this patient had. And one thing is, like, the liver enzymes were hugely elevated, like more than what we would see in normal health. So that was a differentiating point here, that it was something primarily like a fatty liver of pregnancy, and this was a case where you given the best sort of management, still it was beyond our control.
This case I've chosen because this is a unusual case, but if we have aggressive management is mandatory. That's what I wanted to have for discussion. Okay.
We had a case where, not here anyway, it was in the UK, but still the management is similar, where 32 weeks, and we had seen her before 2-3 weeks. Initially, it rose like 54, and then it went to 120. Suddenly, she came saying she was unwell, and it was like 13,000. The enzyme was 13,000. Immediately, we diagnosed it was fatty liver, and they did a section at 32 weeks. And the baby mother, both of them were saved. But it was lucky for her, actually.
Okay. Karpagam, Dr. Karpagam, your inputs on this case?
Yes. Actually, I got disconnected in between, madam.
Okay, then we'll go to the next case. So she's a 20-year-old diagnosed with a GHTN. She was on labetalol. She developed breathlessness and was symptomatic treatment at a private hospital. They thought she's having some respiratory problem, and she was treated there for some hours. And she was admitted to the labor, and she was referred to a government hospital. She was admitted with labor pains and developed acute onset breathlessness with the bilateral basal crepitations in the lungs. Next slide. She was resuscitated with the diuretics and emergency LSES done. Post-op echo showed PPCM. She was weaned on ventilatory support and started on enalapril, Lasix, and other drugs. She was discharged on 17th POD. So, on the slide, previous slide. So, with this case, what do you think is? Sumati ma'am or Dr. Adhika?
Antenatal echo, anything there?
No antenatal echo.
And
but for
probably
peripartum cardiomyopathy, antenatal echo might be completely normal, no ma'am. So we can have a new onset cardiogenic dysfunction.
Yes, but we must know the status of the patient, because we are going to diagnose PPCM later only. So if initially whether it was a normal cardiac status, and maybe she may be a hypertensive for a longer duration, probably undertreated or not diagnosed in the initial visit.
Probably, maybe.
Probably, yes. We may not know about it. We have to go through the history and the previous records, and so that we can confirm what is the duration before, because termination would have been done earlier. If it is we are going to think about the complications, the termination would have been decided earlier.
Yes, ma'am. Yes, ma'am. As you correctly said, it would have been done earlier. And where did this, till this point, where are the opportunities you have missed in
prophylaxis, etc. was it given, ma'am? Thromboprophylaxis?
No. This patient, now thromboprophylaxis was not given. Actually, the GHTN on labetalol, she had a breathlessness. That was not addressed at the onset itself. She was referred to another hospital, and there they were diagnosed again BP was high and emergency LSES. Pulmonary edema. She went to pulmonary edema, resuscitated with diuretics. Then it is a hypertensive disorders with severe features. So she was done. She underwent emergency LSES, and the post-op period she was echo showed PPCM. So this could be either a hypertensive disorder with dilated cardiomyopathy, long-standing, or could be new onset PPCM.
Or ejection fraction, how much when she get discharged, what was the ejection fraction? And whether she was fit to be discharged on that 17th day. That also has got a role because whether she's fit to be get discharged or she need still more hospitalization. That also has to be in mind.
Okay, so she was discharged on 17th. Sumati ma'am, I'm not able to hear what Sumati ma'am says.
Oh,
Others can hear.
whether the patient is fit to be discharged on 17th POD because PPCM.
Ma'am, video off பண்ணிட்டு சொல்லுங்க. Sumati ma'am.
You are not able to hear, huh?
For me, what? Oh. Yeah, could be. So it was done. Actually, she got the fitness.
Manonmani ma'am.
Hello. Hello, Manonmani madam, not audible.
Ma'am.
Hello.
Ma'am, are you there? நான் கால் பண்ணி பார்க்கிறேன்.
Hello. Madam, am I audible?
நான் கால் பண்றேன் மேம் உங்களுக்கு.
Okay, okay.
Yes, I am in. Comment. Yeah. Am I audible now?
Yes,
Hello. Yes, audible.
Yes, ma'am, you are audible. Ma'am.
I think her
Hello,
internet
madam.
is not.
She improved and that was discharged.
Yes, ma'am.
Hello.
Take a look.
Sagi, next.
Sahiti, next slide. Sahiti. Thank you, ma'am. Ma'am. Sure, ma'am.
Ma'am, is this slide only, no, ma'am?
Yeah, slide. We will ask ma'am whether. I think she's not.
Dr.
Fine,
joined in phone.
இப்போ வந்துட்டாங்க மேம் வேற இதுல.
I've joined in phone. Okay. Yes. Next slide போடுங்க. இப்போ audible இருக்கா? Is it clear?
Yes.
Audible.
Yeah. Okay. 1 minute. Yes. So she is 1 minute. Acute breathlessness. Okay. She was readmitted with acute breathlessness. She was resuscitated, referred as P1L1 post LSES on 32nd day. Acute pulmonary edema recovered with the dual inotrope support with elevated urea and creatinine for cardiology nephrology opinion from the nearby CMONG center again back to us 15 days after admission. So actually, and retrospectively, we took the history. The patient said the attendant said she was not taking tablets regularly. So could that be a problem for the particular patient? So this is what you could, because she was treated and she improved and she was discharged as per the protocol after 17 days. But again, she got readmitted with the same complaints. On eliciting history, she said she was not taking drugs properly because she was sort of depressed. That is a history we could get. But again, next slide.
Next slide, madam. PPCM and if the ejection fraction is low and something, now we used to keep the patient till 42 days because the fear of they may not take the drugs properly, they may not know the risk, whatever happens in the post-operative period or postnatal period. Usually, we used to keep somewhat for a longer time so that we will be also sure that we may not lose the patient because they may get readmitted like this. So
Yes.
only at the time of the discharge, even though if it is a PPCM, we used to keep the patient in the HDU ward itself so that she will be under constant supervision and then
Yes,
we can
ma'am.
discharge her. So one thing can be done.
Yeah, yes, point well
Yes, madam.
taken. Actually, this patient, this particular patient, all evaluation, everything was advised, and 17th day, EF sort of improved, and they wanted discharge also. We gave all the advice and we sent her, but then she landed up with this again recurrent problem. So anyhow, we are not discharging nowadays after, up to 20 or 25 days if any heart disease patient. Yes, next slide.
Yes,
ma'am.
madam.
Next
Madam,
slide.
similarly,
Any
in
inputs?
heart disease patients, madam,
Mm.
the postnatal follow-up by
Mm.
the VHNs
Yes.
will also help in preventing the
Yeah, that's
complications.
what, as Shobha madam said, whenever we are discharging high risk in the district group, we will always intimate. So the VHN will
Yes.
go and see the patient. But this particular patient, she went to her mother's place.
The chance of missing.
So there is getting connected to that particular
But they
patient. This
also
VHN,
give cross notification, isn't it?
yeah, they'll
Madam?
do,
They'll
but
do cross
they'll do the cross notification. But the meantime, for within 2 or 3 days, she didn't take the tablets properly. And
Oh,
again, they
yes.
are not
Due to
ready to come
depression.
for admission also because repeated admissions from far off place, they don't want to come. And then she didn't take the tablets also. This is, and yeah.
Maybe she was going through postpartum depression also. Maybe we require psychiatric counseling for these patients also.
Yes, yes. Yes, definitely.
Keep them in the hospital. Telling them.
Yes, madam, till 42 days.
Yes. Yeah, that's what we do. So very, very sick case, we don't discharge them till 42 days. But this patient somehow she slipped out and she landed up in mortality. So
The VHS may not be in a position, they may not understand the whatever the complications arise, they may not know. But here the echo, they have told us moderate to severe MR.
MR.
Yes.
Yeah, fine. Next time when she got admitted, it was 32% EF with the moderate to severe LV dysfunction and moderate to severe MR, peripartum
Yes. So
cardiomyopathy.
only asked about antenatal echo.
No,
Because if there is any lesion is there, it will be modified. We have to modify our diagnosis. So in the postpartum period, they have told that it's moderate to severe MR. Probably it would have been in the antenatal echo also.
Probably, yeah. But now we are picking up more cardiac cases because of the earlier echo for all the patients. So many cases are coming asymptomatic patients. So now it is better off to treat all these patients. Yes. Next slide. Next, I think one more case we have. Is there a time?
Yes, ma'am. We have up to 7.
Okay.
Up to 7.
Oh yes. So this patient, was the investigation report. On double-blind drop support, total count, hemoglobin was 11, total count of 16,500. Sort of.
But SGOTBT elevated, ma'am.
Elevated, Shama. So she went in for multicysts because of the all this hypoxic failures. Next. Next.
Next slide, Sagiti.
Next slide, Sagiti.
Cardiogenic shock.
இல்ல இது அடுத்த பேஷண்ட் போட்டாங்களோ இல்ல இது மேடம் நெக்ஸ்ட் கேஸ் வந்துட்டாங்க இவங்க அப்ப இது ப்ரீவியஸ் கேஸ் போங்க இந்த இதுக்கு முன்னாடி ஸ்லைடு போங்க டபுள் ஸ்லைடு தாண்டி வந்துட்டாங்க இது அடுத்த கேஸ் இது அடுத்த கேஸ்
ஸ்லைட் தான் இல்ல அதே கேஸ் தான்
Because cardiogenic shock and ischemic hepatitis.
இல்ல இது வேற இல்ல
they have referred the patient because of elevated urea and
elevated urea RFTS. Next hyponatremia again. Next slide. Next. Okay, again same patient. Next. Same echo didn't improve. Next.
Intropones, that one only, no, ma'am? Inotropes.
So same at that one only. So inotropes for some bruise or infusion continued. She didn't improve. Again, ABG, but actually we tried so much with all the system support and ABG, metacalcinosis, everything certain. Next. But next slide வரல. அடுத்தது. Next. Corrected. So very sorry for this internet connection and it is not coming properly. Okay. So,
You are not audible, ma'am.
Am I audible?
No, ma'am.
Okay. I mean, one more case is there. If it next slide, am I audible now?
Yes, ma'am.
Now audible,
Okay.
Mano.
Now okay. Next slide.
Cause of death. That one only, no, ma'am.
Yeah, this same only. Peripartum cardiomyopathy, severe left ventricular dysfunction, cardiogenic shock. So because the second time she got admitted on 35th day, because the hypoxic problem, all the systems went in for shutdown, renal, lung, and hepatitis also. So this patient, maybe as Sumati madam said, it should have been kept for 42 days, maybe should have survived. So this is again the antenatal echo for diagnosis of cardiac lesion. Maybe should have given better care in the first admission itself.
Yes.
So Partograph and Clarita, you are on this.
Ma'am, any breathlessness, even now we get at 25 weeks, 26 weeks, we should admit them and immediately. I think better to get an echo done because people are obese and many of them have hypertension these days, raised BMI, all these PCOD complications we have. So better to admit to an echo, even if it was done earlier, and pulse chart and the news chart helps actually. So
Yes, definitely.
It's also important.
Yes.
But we are now
Okay.
routinely doing echo, madam, for all the antenatal mothers.
Yes. It has been done from the
It is
PHC.
mandatory, I think, now.
Yes.
Everybody gets an
Yes,
echo
madam.
done.
We do it
Actually, in Tamil Nadu, we are doing not through
Yes,
all
the
the
national
cases.
information. Guidelines are not that much, but in Tamil Nadu, we are doing for all
yes, madam.
antenatal mothers. At least
Yes.
once the echo to be done.
Yes,
So
ma'am.
that
We are
we have
picking
been
up quite
followed
a few
almost
cardiac cases which are asymptomatic. So it's actually good. And learning points, like Sumati madam said, was like from the first discharge to the second admission. Maybe if she had had an intensive monitoring, it would have been better. And then when she came in for the second, I think it was a point of no return. She had already had a pre-renal shutdown and multi-organ dysfunction. So from there, and day 32, we couldn't have done anything, but actually a learning point.
Yeah. And then yes, ma'am.
No, actually, we had a exactly similar lady, the 40 years, 30, I think 39. I mean, she was 40 years old, third gravida. We have done a cesarean during COVID time. And then she wanted to go home. But the third day, similarly, she developed edema, and she became unwell. But we started on metformin for high sugars. Then we thought, we all thought because the swelling was due to anaphylaxis. Immediately she was swollen. And then, but she was tachypneic also. So we referred her to a medical college here, Tirunelveli, but she escaped from the ICU and she went home. But she was she had severe dyspnea in a week. And then she came back. Luckily, she went to TVMCH. We again referred her to TVMCH and then she was diagnosed as cardiomyopathy. She was started on all the drugs, thromboprophylaxis, and she survived. But she's fine now.
Yeah.
But her immunity was, at the time it was like 45% when she went to TVMCH. So it was not
Yeah.
too.
Thank you very much. Yeah. Thank you, sir. PPCM diagnosed and on treatment, we are saving so many patients, but this patient, we couldn't make it.
And one more thing is any breathlessness, we shouldn't, whoever is treating the antenatal patient should think of any cardiac problem with the pulmonary edema she is having. Because many times that took even a few hours of land up in problem. So this point, this particular patient, breathlessness and pulmonary edema, she developed within a days, 12 hours time. Even though she was delivered and the PPCM she had and maybe should have been kept here for a long time, she might have survived. So next case, this is the last case. We shall rush through. Next slide. Swagiti. இல்ல அப்புறம் அடுத்தது next
slide அம்மா.
Next slide.
Next pa. Okay, she is a 29-year-old case of Raimi with a 32 weeks PLHA on ART with a Cori cor pulmonale, Cori secondary pulmonary hypertension, cardiomegaly, pericardial effusion for further management. She had cough for 2 days, pain abdomen, only on cough, no chest pain or palpitation. She was diagnosed with PLHA 6 months back on ART. So only after becoming pregnant, she was diagnosed with PLHA on TLD regimen. Again, she was admitted previously for severe anemia, treated with 3 units of blood, and she had thrombocytopenia also. Next, CT thorax on a next slide, Sagiti. CT thorax was So admission, she was tachypneic, 30 weeks in breech presentation. Echo showed 60% ejection fraction, moderate PAH due to PLHA, moderate TR, normal LV function. She was advised tablet Lasix and high risk for continuing pregnancy. Peripheral smear dimorphic anemia, X-ray chest showed cardiomegaly, bilateral lung fields clear. Manual platelet was 75,000, sputum AFB negative and sputum culture sensitivity no growth because she was having continuous cough. Next slide. Next. So she had progressive dyspnea, treated with diuretics and NAC. 14th day of admission, she had PPROM and planned for emergency section in view of PPROM with breech. Delivered a boy baby of 1.75 kg. Immediately after the delivery of the baby, she went in for arrest. Vitals, pulse, Cori, BP, Cori, SPO are not recordable. CPR started, inotropes initiated. Again, CPR continued, could not be revived and declared dead 40 minutes after delivery. Next slide. So, next. So, cause of death, Cori amniotic fluid embolism, moderate PAH, PLHA positive. So, I would like all the panelists' opinion regarding this patient, cause of death.
Pulmonary hypertension, maybe because she
Yes,
was
madam.
having PAH, that may be the secondary to the respiratory causes, and it's very difficult to manage because already she is PLHA positive also, and she is on treatment. But termination of pregnancy, that is now it is 32 weeks. So probably the initial visits, how she was followed up, that antenatal visit itself, probably in the earliest phase, how was she, and whether she had initially itself breathlessness or any lung changes was there, that is more important. And also probably the cause may be the pulmonary arterial hypertension. So that usually, even after, what is the type of anesthesia given for this patient? Anesthesia during cesarean section. GA. I think if it is GA, very difficult to extubate the patient. GA means it is very difficult to extubate also for these patients. They prefer usually epidural, and that will be better, epidural, because we intubate, very difficult to extubate. These patients will be having a oxygen saturation, and they won't that much recover immediately. They won't recover because immediately the death was also immediate, very short period.
On
of
table,
sleep.
very short.
Yes.
On table, she went in for arrest and she could not be revived. Lalita and
immediately after the delivery of the baby, she developed arrest. So it is most most likely to be amniotic fluid embolism, though this diagnosis is never accepted. It is a diagnosis of exclusion, but the presentation looks like amniotic fluid embolism because we have seen in normal delivery as well as in cesarean. Immediately after delivery, the patient collapses.
But
So
this
the
particular
possibility of
patient
amniotic
was
fluid embolism.
already, but
This
it
patient
was
is already
Korean.
anemic and a very compromised cardiovascular system and respiratory system. Added on amniotic fluid embolism is
Anemia also. Yeah, a severe anemia also. So
anemia,
everything added
severe
on.
anemia. So
Multi-organ
that is the reason
dysfunction.
she is having effusion in all areas.
Yes.
She's
So
not
actually it was the
also low. Platelet count was also low.
Also
all,
low. So
all the systems
PLHO.
got
Yes, madam.
deranged almost all the systems, multi-organ dysfunction.
Yeah. Lalita was saying some.
Yes. Yeah, I had muted. The thing is, like, she was diagnosed as HIV, like PLHA in the PHC, and then in between, for the past 6 months, whatever investigations was done, was the anemia identified and treated? All that we don't have any information. She was referred only at 32 weeks, and that too with cor pulmonale.
No, previously she was admitted and blood was given for anemia.
Okay, so anemia was treated, but then was she evaluated for the cor pulmonale or pulmonary artery hypertension? Because if we had diagnosed that PAH initially, we could have offered her termination rather than letting her go on to a third trimester.
Yes. Yeah, correct. Radhika Gauri ma'am.
Yes, we could have. That is why the preconception counseling. That's where it comes. We have to. I think.
Actually, this particular patient was not aware that she was PLHA positive and she became pregnant. Only after pregnancy evaluation, she was identified to have PLHA. So that is the one point where she was not diagnosed preconceptionally. And heart disease, probably PH also was missed. So this is again.
Yes, ma'am. Interstitial lung disease also could have been there. Maybe.
Probably, yeah.
Leading to the pulmonary hypertension. Could be some interstitial thing, pneumonitis, or due to some interstitial lung disease must have been there. Otherwise, suddenly she cannot have a pulmonary hypertension.
Madam Manonmani, I think that was evaluated, madam. The lungs were clear.
No, lungs one actually she had she had recurrent cough. So the cor pulmonale only because she was TB done negative, but then the slides padunga Sagiti.
Yes, ma'am.
Yeah.
Recurrent cough.
She had recurrent cough. That's why she underwent CT chest and X-ray and all. It showed cor pulmonale. Previous slide.
This one?
1 minute. Previous one, pa. Is it previous? The one prior to this. Yeah. So, Echo and X-ray was taken. Peripheral sputum AFB negative. But then X-ray chest showed mild cardiomegaly and lung fields were clear and no pleural effusion. But echo showed moderate PAH because of PLHA and moderate clear and normal LV function. She was put on Lasix also and suggested high risk for continuing pregnancy when she was 30 weeks. But then within 2 weeks, she went in for draining and cesarean was done. Okay. Sagit, any slides irukka parunga?
Yes,
Next.
there were some more slides.
Now one more case is there. Time avladha mudinjirucha. Shall we close with this or?
No, we'll do this, ma'am.
We'll do this. Okay. Next one, pa. Yeah. She's so 29-year-old booked and immunized in other state. Antenatal period uneven, full emergency LSS done in a private hospital. DCDA with first twin transversal in labor. Again, patient developed the GTCS followed by cardiac arrest. She was intubated, resuscitated, and shifted to another private tertiary care with inotropic support on the same day. Next slide. Next. Sagiti, next. She had another episode of GTCS during transit. In private hospital, her uterus was found to be atonic. APG showed severe metabolic acidosis. PPH measures were taken, resuscitated with the fluids, blood products. Again, the patient had cardiac arrest and revived. She was maintained on moderate hypothermia as a part of post-resuscitation care. Poor neurological sequelae explained, and hence patient got discharged AMA, and she got shifted to our hospital. Next slide. Next. So here she was on mechanical ventilation, unconscious, on inotrope support. Peripheries were cold, bilateral pupils not reacting to light, no pedal edema, BP 60 curie, pulse rate 130, SpO2 99, CVS RS, bilateral air entry pressure with mechanical ventilation, abdomen no distension, uterus firm and contracted, dressing clear, PV no undue bleeding PV, hemoglobin was 7.4, WBC 16.9, and creatinine 1.4, coagulation normal. Ultrasound showed minimal free fluid abdomen with increased serial echoes. Next slide. Next, okay. So she was continuing with the support with all the opinions. Echo showed ejection fraction 60%. She had third arrest here, and second of the admission, she couldn't be revived, and she was declared dead. Cause of death was post-cardiac arrest, MOTS, amniotic fluid embolism, dead admission at the interval 2 days. Because she was, next slide, she was received in the ventilatory support after 2 arrests. After coming here also, she had 2 arrests. So this case, where for us to avoid maternal death.
Was an imaging done because she had GTCS? Was an imaging done anywhere, even the private hospital?
Yeah, in the private hospital it was done. It was only hypoxic ischemic changes in the brain.
Anesthetic complication, anything was there, or
could it be?
But a PPH, madam. PPH had.
So first delivery, we have twins, and first twin was delivered. What was the immediate, if they diagnosed PPH or amniotic fluid embolism, how they have resuscitated the patient? What are the components they have given? How they have resuscitated? That is more important. On table resuscitation for this case, because after the first delivery, first twin, the patient has a complication. I think so. So at that time, the resuscitation, what they have done?
Probably the resuscitation, twins followed by bleeding and management. The blood replacement is not adequate. So at that time she went in for DIC.
HP dropped. HP dropped from the
7.6 when they referred. 7.6 when they referred to the other hospital. So what was at the time, if they have resuscitated the patient at the time on the table, patient would have been crossed this period, because adequate transfusion, not only the FFP, everything to be done, the cryo, everything has to be given, and probably the patient was in DIC or not. That is not told.
Yes, she was in DIC and corrected in the private hospital. Private hospital. Yeah.
So at the time on the table, resuscitation was not adequate with adequate replacement.
The blood was not reserved adequately. So only 1 year of blood they were given after the patient went in for atonic PPH and failure of medical management. So probably at that time, if she had been corrected,
and hysterectomy also, if it is not both resuscitation and if it fails, they can go for a hysterectomy also to save the mother.
Yes, ma'am. So Lalita and Radhika Karpagam opinion on this case. I think this is the last case.
So my thing was, if it was a PPH, even cardiac arrest will usually occurs around less than 7 grams. Usually it should be all right now, ma'am. Why was there a cardiac arrest so soon? And why did she have a cloning? Could it be high spinal, ma'am?
There's no referral slip.
If they intubate and they will high spinal, they can recover also. Yes. One is over distended uterus and probably anticipate The PPH
Totally
bundle.
agree, but it's
You have to put a PPH bundle and she is under what risk and everything to be planned. And resuscitation would have been done earlier on table.
These patients have to be referred even antenatally at the end of, towards the earlier, even earlier to the anesthetist. Sometimes when the BMI is high, these infertility patients we have to refer them to the anesthetist so that they can be ready, even if they come here, especially in the government setup. We have to refer them early so that they can be ready with the if they come as an emergency with the rupture of membranes, they're taking up, then if they will be familiar with the patient and they can have a plan for the patient, and 4 to 6 units blood should be there. So these precautions we can take from this lesson. These are the lessons from this patient.
The ART patients, they will be on also, sometimes they will be on anticoagulants also. They will give all these drugs and everything. The patient may be on a regular follow-up with them. When we receive, we may not know what are the drugs the patient would have received, everything. She may be on definitely low molecular weight heparin and other supportive drugs also. So all this, when we receive the patient in a stage, it is nothing can be done more than this.
Absolutely.
Lalita.
And she has been in 2 private hospitals before she came to you. So in the first hospital, the first thing they started inotrope and then referred to the second hospital. In the second hospital is where they have encountered PPH and they have corrected the metabolic acidosis and all. So if there was a hysterectomy that should have been planned, that was there. But then there itself, she had again arrested. So for them, it was like more than doing any other intervention, they wanted to refer her on because it was anyway a bad case to keep. So I think multiple cardiac arrests there and hypoxia, and you said it was HIE. So it was actually at that point, if she had been directly referred to the government hospital, I think she would have had a better care at that point. So this is like shunting from one place to another also. You have to go back to the history and see everything. And by the time you understand what's happening, the patient is already gone.
Yes, madam. The birth planning is very important.
Yes.
As already all madams have already told. And multiple places, I mean, referrals or changing of hospitals, that itself would be a cause. And active management during immediately after delivery would have done a lot in saving this patient. They should have adequate blood and blood products ready when they are managing a multiple pregnancy. So active, it is the intrapartum incident that has been the reason for all this. So proper planning would have saved this mother.
Yeah.
And
Yes, thank you all.
Ma'am said early.
Early intervention.
If the facility does not have the, I mean, all the blood bank facilities and everything, better to refer to the tertiary care center.
It means they shouldn't have taken the risk. Yes. Okay,
Yes.
I thank all my panelists, Sumati ma'am, Lalita, Radhika Gauri ma'am, and Karpaka ma'am. Yeah, for your wonderful participation, active involvement, and discussing all the points where you have missed the link. So I thank Sambat ma'am and TNFOG team for giving us this wonderful opportunity. I thank Usha ma'am. Actually, the slides I sent and madam said these are all the real cases because we had seen the case in live. The madam said for me to discuss, and I'm very sorry for interrupting in between for the interruptions because the net connection was not proper. Thank you so much.
It's okay.
Thank you, Manon Mani madam. All the cases were really very interesting and thought-provoking, and has also will help us in future to manage such cases when it comes to us. Thank you.
Thank you. Thank you so much, ma'am.
Thank you.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you all.
Thank you, ma'am. On behalf of TNFOG, I would like to thank Ramani ma'am, Sampath ma'am, Saravana Kumar sir, and Dr. Jayashree Gajraj ma'am, who's been kind enough to be the chief guest, and the judge, Dr. Karpagambal Sairam ma'am, who pointed out rightly in the CTG and the other talk, Partograph talk. And then the MMR topic, MMR, how to reduce. Dr. Shobha ma'am's topic was also thought-provoking, and we knew about the government measures taken by the government to reduce the perinatal mortality and the maternal mortality. And case scenarios were excellent. Thank you very much, Manon Mani ma'am. You've done a lot of work to give us all the scenarios, and all are interesting. and not the usual ones. So it's very good. Thank you, ma'am. Thank you, panelist Dr. Lalita ma'am and Dr. Sumati ma'am. She gave her all important points like early hysterectomy. So medical college side, we knew what's going on in your side. And Karpaga ma'am, thank you so much. And I thank Sahiti for her IT support. Thank you so much, ma'am.
Yeah, thank you.
Thank you.
Yeah. Thank you, Swagita and Priya. So for helping in technical